Information is clinical and has a clinician. The clinical materials are managed to
One of the things I was thinking about is in terms of this CME as opposed to others is that the approach is different and complementary.
The amount of energy and passion that
هذه انرجيا انفشن خطيره دي
people really are
انرجيا انفشن
and they
The unique gift for breaking down very complex and complicated issues inside of the heart to easily digestible information.
Taking advantage of what we know about how people learn, not just through the one-shot deal, but having it linked to sequential learning experiences over time, which I think is essential.
That's why they have a competition groups. I'm already volunteering to everybody to get back in there and help them out.
the method of giving information to us is truly expanded.
Ladies and gentlemen, it is with great anticipation and humble thanks that the Neuroscience Education Institute welcomes you to the 2006 Athens Psychopharmacology Academy. Our entire staff is very excited that you have chosen to participate, and we would like to welcome you to this event. It is our desire that your time with us be both enriching and enjoyable. Thank you again for making NEI part of your plans for 2006. And now, the chairman and founder of the Neuroscience Education Institute, the Duke of Dopamine, the Sultan of Serotonin, the nemesis of neurotransmitters everywhere, Dr. Stephen M. Stahl.
It's such a great pleasure to be here and have you here for a beautiful day in Athens. We're going to have some fun, but we're going to work hard. We have 2 days of rich material in front of us, and with your handout, everything that we're going to have on the stage will be in your handout. Sometimes we will skip some slides, so just move forward a little bit. It will all be there. I'm Steve Stahl, and I'm from San Diego, and last time I was here, I was staying in Cape Sunion, and I was going to the Olympics, and driving my wife from Sunion up to Makakalu. I can't believe the transformation of this country. It's amazing. I hadn't been here since 1987 till 2004. So many congratulations on everything and all the development. We're going to have about 500 people here today, and we're going to have a lot of fun because, as I said last night at the banquet, this is a very great time to be in this field. And we're going to advance some of the information, genetics, pharmacology, a little bit of anatomy. Yes, I'm sorry, a little bit of learning how the brain is anatomy, the wiring. It's important for a 21st century psychopharmacologist. So, I'm going to have my colleague explain a little bit about our organization of the course this morning and why we do the education with the design that we choose. We have these keypads in front of you, which we very much hope that you use. They are very much involved with proof that if you use them, you will learn and remember much better. This is why we put them here. You will see we have tests just before the lecture, and then we ask the questions again at the end of the lecture. This will show you whether there's been learning, but it'll also tell you whether we've been a teacher. So we will be using these. Later, I will be actually tomorrow using them to choose drugs with you about cases for my practice. So, there's a reason for this, and it has to do with educational design. We're very interested in not only teaching science, but using the science of teaching. And the science of teaching can make a design so that you will have a little bit of fun and so that you will remember better. So, the person who has actually helped me with this and who is an expert on education is the president of NEI Global, and his name is Rick Davis. He's also one of the speaker coaches. We do some faculty training. Some of you may have taken some faculty training from us. We not only teach psychopharmacology, but we teach teaching. And Rick is the professor of teaching, if you will. And so I'd like to ask him to come up and explain to you a little bit about the agenda today, some of your materials, a little bit about NEI, and then I'll come back up and start the first lecture, okay? So are you awake? We'll have a break, but let's get to work. So, the president of NEI Global, my colleague and friend, Mr. Rick Davis.
Good morning. It's nice to be here with you. We do want to get started and take a look at things. Steve mentioned that there's a madness, or maybe I should say there is a method actually behind our madness when we do our education. And years ago, as we started to take a look at the different educational formats, and we experimented as well. We tried to find one format that gave people enough time to really spend in a subject that would give them the level of understanding that they needed to actually improve their practice and increase the outcomes or the result of the outcomes for their patients. And so we developed what we call our academy, which is a two-day, we'll be going through here, a two-day forum to really delve into the subject matter that we need to. Also, we expanded that, and we did that format for many years, for about 6 years, and then after 6 years we had people tell us that they would like to have a longer period of time. So once a year, we also have a Congress, and that's a 4-day seminar, and that gives us an opportunity to do some things educationally that you don't have time to do in just a 2-day format. So we'll do the academy here. One of the other things that happens is this gives you an opportunity to really delve into a topic and to be able to drill down in the Congress. Then we'll have a little broader topic things. That gives you a little bit of background on our Congress and academy formats. Now, one of the things we wanted to do is to build things on almost a curriculum type basis. And so we developed a psychopharmacology certification program that actually ties into the different educational initiatives that we offer. And at the end of the study of that, someone gets a master psychopharmacologist certification. In fact, if you'd like more information about that, you can go to our website, which is www.neiglobal.com, and that will tell you all about certification and what's necessary to do that. One of the reasons that we thought that was very important, because to give somebody a course of study that would really give them A to Z as far as the field of psychopharmacology is concerned. We're very excited about something we just started in 2005, which was our membership. And we have an international membership, so I would invite you to join us as a member as well. Again, you can seek out information, and in the folder that you were supplied for the meeting, there was a flyer inside. It gives you some information about membership. And we started it back in 2005, and in 1 year it grew to 1,200 people. And we anticipate that at the end of 2006 it will be approximately 3,000 members in our organization. And some of the benefits that you see there, if you, we have our monthly newsletter, which is part of it, and you also have an opportunity to, if you buy any of the educational materials or even...
Do they cause the disorder of major depression or the symptoms of major depression? The answer probably is yes. Right now, we are looking at symptoms more than we are looking at disorders. So our learning objective is to explain the different symptoms put together in a cluster. That means a syndrome. Actually, the DSM and the ICD-9 are full of clusters of symptoms put together, making disorders or syndromes out of them. There's no diseases in DSM. We wish they were diseases, but they're not. They're disorders. They're clusters of symptoms. And we're going to find that they're related to abnormal brain nerve activity. But in different parts of the brain. Do you think that all activity of the brain occurs in all parts of the brain? No, the brain is specialized. So certain functions are in certain circuits, and other functions are in different circuits. And in modern psychiatry, we have to know a little bit about anatomy. Only a few things, and it'd be very easy to learn this. We're going to discuss how neurotransmitter circuits can modify activity in those brain areas. In other words, neurotransmitters talk to nerves. And if they're talking to the nerve that has abnormal activity, it could fix it. If you have drugs that will change neurotransmitters, that is the way in which they work to stop symptoms, because those symptoms are mediated in a sick circuit. And your drugs reduce abnormal nerve activity in a sick circuit. And if it does that successfully, it will stop the symptom. So we're going to examine contributors to the development of this abnormal neuronal activation, and including the fact that if you have bad experiences as a child, you may irreversibly damage your brain for life. The circuits have a sick way of learning. They can learn to have trauma, and sometimes that trauma lasts a lifetime and changes the brain so that when it becomes an adult, stress acts differently to break the brain. So we will be talking about stress based upon early life experiences and the HPA axis, the hypothalamic pituitary adrenal, HPA axis, okay? So here's the pretest. I'll ask you these questions again. It doesn't matter for your competition whether you know the question now, but it matters a lot after this lecture. Number one, which of the following areas of the brain are linked to emotions? A, medial and orbital prefrontal cortex. B, anterior cingulate cortex. C, amygdala. D, A and B. E, all the above. What's the best answer? Just punch it in on your keypad. And let's see what you think. That's a pretty smart audience. Let's see if you know this one. Abnormal activity in dorsolateral prefrontal cortex may result theoretically in what? A, suicidality and major depressive disorder. B, negative symptoms in schizophrenia. C, attention problems in attention deficit hyperactivity disorder. D, A and B. E, B and C. That's also pretty good. So, let's review a little bit about the important circuits and the symptoms, particularly as related to depression. You will find out during this weekend that the same circuits will come up again and again. That's because the brain only has a certain number of highways to carry its symptoms out. There's a certain number of highways to carry cars out of Athens. There's only a certain number of highways to carry symptoms out of the brain. And one of the things that you're seeing happening in our field is going, Professor Stefanos mentioned it last night, from categorical descriptions of diseases like DSM and ICD, this is dying. We are going to dimensional. That's my lecture today. In other words, cognition is a dimension of psychopathology. It uses the same highway to get out of the brain. And that same highway is for cognitive symptoms of depression, cognitive symptoms of ADHD, cognitive symptoms of schizophrenia. Same circuit, even though it's different pathology. So, different neuroanatomical areas are associated with different types of functioning. There's emotional areas of the brain, and you are right. There's a frontal circuit, the ventral prefrontal cortex, the orbital prefrontal cortex, connected to the amygdala. This is emotional. Cognitive is dorsolateral prefrontal cortex. There are somatosensory areas, some in the spinal cord, some in motor areas of the brain, basal ganglia. Sleep is an extremely important theory today. We will be talking about many things of sleep all weekend. And the idea is that if you have abnormal activity in a certain part of the brain, you're going to have a symptom depending upon the function of that circuit. So obviously, if you have a problem with your sleep circuit, something's wrong with your sleep. If you have a problem with your dorsolateral prefrontal cortex, something's wrong with your cognition. And we all know that the brain is full of juice. And in the juice are chemicals. And in the chemicals are neurotransmitters. And chemicals can stop and start circuits. So if we stimulate or block with our drugs, we can alter neuronal activity. And by doing that, we stop symptoms. So your role and my role as a practical clinician is to modulate this neurotransmission rationally by saying, what's wrong with my patient? What circuit is that in? What neurotransmitter do I need to modulate in order to fix that circuit? And if that doesn't work, let me try another one in that circuit. Let me try two together that are in that circuit. This allows you to construct rational combinations of drugs rather than just throwing drugs at people without thinking. So major depressive disorder is not one symptom. By definition, it must be depressed mood or loss of interest, and then you have to have 4 of the rest of these. And there are other symptoms which aren't even part of the DSM, pain and anxiety. Now let me ask you, if you have depressed mood, guilt and insomnia, and you have depressed mood, hypersomnia, and problems with your appetite, you have the same illness? You have the same disorder? It's called major depression. Do you think all the circuits are abnormal in both of your brains, the same circuits? Not really. The mood circuit's wrong in both of these. But you have an insomnia circuit, and he's got a hypersomnia circuit. So maybe something different is wrong with their sleep circuits. Also, you've got some circuits that are abnormal that he doesn't, and vice versa, right? Now let me give you an antidepressant. Your sadness gets better, but you have insomnia, and you still have guilt, let's say, or whatever. Am I done? I'm not done. Because antidepressants aren't just to treat sadness, are they? Both of these guys need to have every symptom gone. Now, if you still have insomnia after I treat your sadness, I have to think, what's the insomnia circuit and what can I do? And today you will find out that a very smart thing to do in insomnia is to add a hypnotic. Because it's good to get rid of sleep abnormalities. Because we want to have remission. If you have problems with your energy, we might give you a different kind of medicine. It doesn't matter what's wrong with you. I need to ask you questions twice. Once, what's wrong with you at the beginning of treatment? And then, what's wrong with you after my first treatment? Because if you still have something wrong on the list, I'm not done yet. And so this allows us to think of the symptoms and maybe what part of the brain is involved. So one of the easy ways to put this together is that the front of the brain, prefrontal cortex, is the psychiatrist's territory, not the neurologist's. We own that. And at the front of the part and on the middle, that's called medial, and towards the bottom, that's ventral, Actually, you know, the part of the brain that sits over the eye is called orbital. So orbital, frontal, ventral, and medial, these are all terms. And one of the places in the brain that we hear that's in that area is called anterior cingulate cortex, ACC. It's really all the same thing. It's the emotional brain. And certain areas of the brain have emotions in them. Suicidality, anxiety, mood, sadness, fear. Medial and orbital prefrontal cortex. That part of the cortex is connected to a very important area. We're going to see this in some of the scans from the brain imaging. It's the amygdala. I call it the panic button in your brain, is the amygdala. And orbital frontal cortex is connected with wires to the amygdala. And if something's wrong with your emotions, something's probably wrong with your amygdala. And you can prove that because you can put your head in a scanner, and if you have emotions, the amygdala is screaming with neuronal activity. And do you know that one of the big neurotransmitters in the amygdala is serotonin? So would it surprise you that if you increase serotonin in the amygdala, your emotions get better? No, you do that every day in your life. The nucleus accumbens is another part of the brain. This is just below the caudate nucleus. This is famous for being overactive in schizophrenia, remember? Too much dopamine in the nucleus accumbens means delusions, hallucinations, thought disorder, positive symptoms of psychosis. It's also the reward center. So what happens in patients with depression? Bleh, no dopamine, no fun, no reward or motivation, apathy, anhedonia. And there's ways to fix that. One is to recover from depression. Another is to give dopamine into this area. Not too much or you hallucinate, just enough. Another is to have a cigarette. This kicks dopamine into the nucleus accumbens. Another is to have chocolate, sex, or one of Dr. Stahl's lectures. These are all the most wonderful things in life. They will make your nucleus accumbens light up with dopamine, the pleasure center. Maybe not Dr. Stahl's lecture, but anyway. Hypothalamus. These are drive, sleep, sex, eat, drink. And if they don't work, blah, you have vegetative symptoms of depression. So abnormal activity in all of these areas are linked to various emotions of lots of disorders. Today we're talking first about depression. And if you want to look at your handout, much more detail. This is in your book. Let's look at it a little more closely. The most famous parts of the brain for you and me today is, this is an upside down brain. This is bottom flipped up. That's the front. And this is the orbital frontal cortex. And this is the lateral, and up at the top dorsal. This is ventral. So, I hate these words. I apologize. D, L, P, F, C. D, L, P, F, C. It's in your lives. If you want to read the American Journal of Psychiatry, the British Journal of Psychiatry, you have to know D, L, P, F, C. It's in your lives. It's a very famous part of the brain. You want to take a look at it? It's on the right. This is orbital frontal, mood, anxiety. This is concentration, cognition. And too much activity over here is sadness. Too little over here in DLPFC is executive dysfunction. Executive dysfunction doesn't mean people who run corporations and go to prison. This means problem solving in a patient. This part of the brain is abnormal when people can't concentrate in depression. It's also abnormal when people have ADHD. It's also abnormal if you don't sleep and you wake up the next day and you're tired. It's the cognitive highway. anxiety, fear, sadness. And it's very interesting because this part of the brain talks to this part of the brain and it tries to rationalize with it. It says, knock it off. Don't be sad. If you're a cognitive therapist, you're working on DLPFC. So the DLPFC begins to tell the other part of the brain, stop your stupid symptoms. And if it works, it will start to inhibit that activity. This also explains psychotherapy, basically. So here we have it. These studies suggest that the ventral medial anterior cingulate cortex, all the same thing. It tells me, oh my gosh, is this something to be afraid of? In other words, oh my gosh, there's a room full of smart doctors. I'm seeing them all there. I better have a panic attack. That would be if I had social anxiety, right? But if my rational cortex says, oh, all right, they'll be nice to me. They're interested in my field. I've done this before. Knock it off. Don't be afraid. That's my dorsolateral prefrontal cortex telling this part of the brain, don't get freaked out. Because it results in my mood, my feelings. Sometimes they're automatic. The other part of the brain is connected. And it tells me, what should I pay attention to? Somebody who's got his eyes closed sleeping in this room? Somebody drinking water? Or should I pay attention to this thing in my hand? What should I be concentrating on? That part of the brain is the executive. And it tells me how I should deal with my mood. And studies show that these two things have a reciprocal relationship and talk to each other, just like this. DLPFC goes down through the amygdala, and ventral medial goes back up. If this is out of balance, you have a psychiatric symptom. And fixing this is important in making many of our patients better. Did you know that the monoamines down here in the brainstem send messages up here? Dopamine, norepinephrine, serotonin. Dopamine, norepinephrine, and serotonin. Why do you think that the most powerful 3 neurotransmitters out of several hundred in the brain that work for affective symptoms are dopamine, norepinephrine, and serotonin? It's because the nerves go into that area of the brain and regulate it. And you have tools to increase those neurotransmitters there. One or the other or all 3, correct? And this is what you do in order to treat symptoms. Let's take a look at that. From the brainstem raphe nucleus, serotonin comes up and talks to the emotional brain. Noradrenaline comes up and talks to the emotional brain. And even dopamine does, not shown here. And that part of the neurotransmitters regulate the emotion of mood. There are other emotional centers. For example, the amygdala is now involved with serotonin and norepinephrine, but there's very little dopamine in the amygdala. Dopamine instead goes to the nucleus accumbens, which we talked to you about. So these emotional centers are abnormal when people have symptoms such as guilt and suicide. There's also an area of the brain which is cognitive, as I said, and it's dorsal lateral prefrontal cortex. This will not be very painful by the end of the weekend. This will be a very similar term, and you'll see it and not be unfamiliar with it. The hippocampus has long-term memory in it. There's an old joke. It says there are 3 things that get bad when you get old like me. One is you lose your hair. The other is you lose your sex life. And I forgot the 3rd one. Oh, it's your memory. That's it. Your memory is in the hippocampus. Dorsolateral prefrontal cortex is organizing and planning, not memory. Abnormal activity in these areas may be linked to cognitive problems. Cognitive problems are a big problem in depression. And obviously they're a big problem in negative symptoms of schizophrenia. They're a big problem in ADHD. The same dorsolateral prefrontal cortex works here. I got a question for you. Did you ever treat a patient with ADHD? Did you ever treat a depressed patient with the same drug? And did it help the cognitive symptoms of depression? Yes. Why is that? Same highway. And so a psychiatrist learns that if you understand a symptom treatment for one disorder, it will work in another one. And this is a more detailed list, which is in your handout. So you have cognitive functioning being controlled by norepinephrine to the lateral cortex. Look at this new friend, histamine. Have you ever heard of histamine before? Histamine is an incredible neurotransmitter. Also, do you see serotonin up there? No. Serotonin is a great emotional neurotransmitter. But do you know what serotonin does to cognition? It makes it be a little bit worse. Dopamine and norepinephrine and histamine, these are the cognitive neurotransmitters. Do you know that serotonin, when it goes up, it tells dopamine to go down? Have you ever given an SSRI to a patient and have them get a little flat, apathy, they don't really have a lot of interest? Those people are very sensitive to the inhibition of dopamine by serotonin. In the United States, we often treat these people with bupropion. You have it here in many countries for Zyban, for smoking cessation. You may have reimbursement problems, but it's a very good antidepressant, and you can use it off-label, particularly for apathy, because it kicks up dopamine a little bit. The other thing you can do is use an SNRI, but you have to use it at higher doses so you get the norepinephrine. Does anybody know the one drug in psychiatry which boosts histamine? Only one drug. Antihistamines make you sleep. What boosts histamine? Modafinil. Do you have this? Some countries have it. We call it Provigil. Provigil, again, it may have to be used off-label. It's approved for narcolepsy. But if you have the need to wake people up or give them attention, even in schizophrenia, this has been used to treat the cognitive symptoms of schizophrenia, the cognitive symptoms of depression. I will show you some data tomorrow, actually, in the sleep section. So here's some magic tools for you. You have your SNRIs, you have your SSRIs, of course, but you could add to these modafinil or bupropion, if you know your brain anatomy. Now, it's not that hard, ladies and gentlemen, to do cognitive testing. Some people say you need a psychologist for 8 hours. Some people say you need a fancy computer. Some people think you need a big stack of papers that takes hours and hours to progress. No. You can do it at the bedside. You know that? In fact, cognitive testing is done by policemen every day. Do you believe me? They will test motor function. They will test executive function, like saying the alphabet backwards. You know that's a form of executive functioning? I will show you right now how easy it is to do cognitive testing. Are you ready? Let's take a look.
Well, I'm great. I'm doing okay.
I'm not so good, because you were weaving all over the road there.
Well, so get one thing straight. I have not been
We need,
drinking.
okay. Right hand to the nose. With the left hand.
All right.
And back out. I need you to recite the alphabet from Z to A backwards as fast as you can.
From
Can you
Z
do
to
that
A?
for me? Yeah.
Sure. Z, Y, X, W, V, T, S, R, Q, P, O, N, M, L, K, J, I, H, G, F, E, D, C, B, A.
Remarkable. I've actually never seen anybody do that. I'm not worried about your bladder right now.
Sure. 10,
All right.
step, 5, 6, 7, 8. Step, bump, step, bump, step, bump, step, bump. Over, right, kick ball, change, step, clap. 5, 6, 7, 8.
You know what would be good is if you get kicked and then you gotta put that in a barrel turn and then,
سكران.
you know,
That was good.
that would be,
That was really good. You a dancer?
no, I'm just drunk.
So even psychiatrists can do roadside testing, right? So we need to test our patients' cognitive functioning because they may need different drugs than patients who have emotional functioning. So we can also talk about somatic functioning. This is becoming famous because these symptoms, particularly fatigue, retardation, and pain, are very poorly treated by serotonin. And so you need to have norepinephrine or dopamine, usually norepinephrine and serotonin. This is important because you're finding that the pathways that are important for regulating motor functions are norepinephrine in the cerebellum, serotonin in the striatum, and dopamine in the striatum. And to make symptoms of agitation or retardation get better, or fatigue, you need to have noradrenaline as part of the treatment. Here you have somatic fatigue. These famous pathways that go down the spinal cord are the most important for treating physical fatigue and pain in depression. Histamine, noradrenaline, and particularly dopamine, more so than serotonin, are the most important for mental fatigue. So the point would be, if a patient has fatigue, you need to think of the neurotransmitters that you have to boost in order to help. Because one of the most important questions when you're treating a depressed patient, many people after treatment still have fatigue. It's one of the most common residual symptoms, and we'll talk about how you approach this. Sleep is a horrible symptom. And this is both in the hypothalamus and the brainstem. Let me show you some of the wires. What you have is the serotonin going into the brainstem to control sleep, but you also have this very important neurotransmitter histamine in the brainstem. And when you're not awake, histamine is off. This is called the sleep-wake switch. What is the on switch? Histamine. What's the off switch? GABA. So, if you don't sleep well at night, your on switch doesn't work. And you're sleepy in the daytime. So you can treat that two ways. One way is in the daytime you kick histamine on. The other is at night you kick GABA on. And sometimes you have to sleep very well at night so you are very awake in the daytime. And this is often abnormal in many mental illnesses. Sometimes I call sleep the psychiatric vital sign. It's like psychiatric fever. If your sleep is off, there's something generally wrong with you. You don't necessarily know what, but you're not in remission and you're not well until your sleep is normal. And we have many tools for that, both to wake you up in the daytime by kicking histamine on with modafinil, for example. Blocking serotonin is important. This is why trazodone, which is a 5-HT2A antagonist, or atypical antipsychotics, sometimes particularly Seroquel, which is a histamine antagonist at night, and a histamine agonist in the daytime is modafinil. So you need to know how to use the drugs in order to get the symptom relief that you want. So in summary, the different brain areas are associated with different functions, and therefore different types of symptoms. And when there's abnormal activity in these brain regions, you have a symptom. And if you know that, you can be an amateur neuroanatomist and understand that these brain areas get projections of neurotransmitters. And that's cool, because you have drugs to modify them. Now, the whole brain is not abnormal in all patients, That's why everybody has to be diagnosed individually, one at a time, the specific symptoms in each patient. And if you know that, it allows you to figure out what's wrong with that patient, even after treatment, when they only have a partial response. And then you can go back and say, what else do I have to do to get the job done? Post-test. Most of you knew the answer. Let's see if we can have some learning. Which of the following areas of the brain is linked to emotionality? A, medial and orbital prefrontal cortex. B, anterior cingulate cortex. C, amygdala. A and B, or all the above. And the answer is all the above. Boom! And let's take a look. Good learning, 68 to 88%. Let's do a race. Oh, very close. Looks like red might have won. Yes, it did. Good, red. How about D, L, D, F, C? Is that suicide, negative symptoms of schizophrenia, attention deficit, A and B, or B and C? And the answer is suicide is emotions. That's the wrong answer. B and C. Good. Oh, now the blue comes back. Oh, red won the whole overall by just a nose. Green, it's time to make your move. Here's the pretest for the last half of my lecture. Do you know the answer to this? A normal response to stress requires glucocorticoid feedback to the hypothalamus. This is your famous HPA axis. Do you know what that glucocorticoid turns off? A, CRF. B, ACTH. C, this is also called BDNF. A and B, or A, B, and C? What gets turned off normally? No. Here's the point. Normally, glucocorticoids, if you're afraid of a hostile Greek audience, and you want to run away under stress response, acutely, ACTH and CRF are turned off because I have cortisol that goes up. Normally, BDNF is not turned off. So the right answer here is D. If you turn off BDNF, it's because you are a crazy guy like me who lectures every day and has chronic stress. And the abnormal response, all of a sudden, is to turn off BDNF. It's not normal. It's abnormal. If you turn off BDNF, your brain shrinks. I'm shrinking. Ah! That's because it's a brain fertilizer. So, you don't want to do that. But unfortunately, some psychiatric illnesses do that. But it's not normal. The normal response is to leave BDNF alone and to very acutely stop ACTH and CRF. Therefore, the answer would have been D. Next one. Studies have shown the benefits of antidepressants include what? Do antidepressants decrease BDNF, increase CRF, or reverse hippocampal atrophy? A and B, or A and C? No. Let's go backwards. Antidepressants are good for you. Why would would you want them to decrease BDNF? That would be the bad thing. You want it to increase BDNF. In fact, one of the interesting things is by an unknown mechanism, I will show you a slide, BDNF is increased by antidepressants. You do not want to increase CRF. Did you know that there's 4 drugs in development by the pharmaceutical industry today to block CRF? They're CRF antagonists. So you want antidepressants to block CRF. And if you increase BDNF and block CRF, you will reduce hippocampal atrophy. So the answer here is C. I will show you. And in one moment, did you know that even Alice in Wonderland knows this? I will show you a nursery rhyme to teach you the story in just one moment. So the answer here would be C. Next. So the normal stress response is, oh my gosh! Boom! CRF comes out of my hypothalamus. Boom! ACTH comes out of my pituitary. Boom! Cortisol comes out of my cortex. And I'm running away from the saber-toothed tiger. I get into the tree and go, whew, and shut this off. You need to be able to shut this off, because if you don't, eventually stress will go to your DNA and tell the gene for BDNF, stop. If you don't have BDNF, you're in trouble. BDNF is the brain fertilizer. BDNF is like the gardener, manure. If that goes, your brain begins to lose some of its dendrites and shrink its tree, and if it goes long enough, the nerve will die. This is not good. And that's what we think happens in brains of patients who have stress sensitization. Let's say you're abused as a child. Your brain may be abnormal, but you may have no symptoms yet. But if you then get abused again as an adult, you break down. Whereas that same abuse in an adult, for someone who had nothing wrong as a child, is silent. It's because the brain has been stress sensitized. So prolonged stress, or early stress, either one, creates prolonged glucocorticoid release, and this is toxic because it causes hippocampal atrophy. Are you aware that there's glucocorticoid antagonists being developed to prevent this? That's why. This is toxic. Because this will create a feed-forward system, which is damaged brain. And it goes around and around and around, and your hippocampus gets smaller and smaller and smaller, and this causes more and more problems. Did you know that under mental illnesses, your brain really, literally shrinks? It's not merely suffering to have a mental illness. It can be damaging to your brain. And this is why people need to be in remission. Symptoms don't necessarily just mean current suffering. It can mean my brain is literally degenerating. And if you don't stop the symptoms, you don't stop the process. And if you do that, and you allow symptoms to continue, it may mean that your brain is going to be harder and harder to treat. You're going to get more and more episodes, and the drugs will work less and less. So this is important to interrupt this process. You have decreased hippocampal volume. And let me show you something that's very important about childhood exposure to stressors. Because hippocampus may only really shrink if you not only have adult problems, but if you were preceded by a child problem. Because if you have a child with PTSD, their hippocampus is normal. But if you keep exposing them as an adult, then it gets smaller. Let me show you. Here's some this is some MRI scans. And what you have here is a depressed woman who was abused as a child. And she is going to show you that she has a small hippocampus. In fact, it's interesting, if you have a depressed woman who wasn't abused, she does not have a small hippocampus. And if you have a healthy subject, it's the same. That's the left side, here's the right side. What this is saying is that you have to be both abused as a child and subsequently have stressors as an adult. 1 + 1 = 10. That's the problem. And if you look at this, women with a history of childhood abuse have increased rates of depression, PTSD. In other words, a soldier who was abused as a boy may be much more likely to have PTSD in combat than if he did not have this. Or a woman who gets raped as an adult who has had abuse as a child is much more likely to have this plus a decreased type of hippocampus. So all of these things are increased. It's though the brain has only one insult it can take. And if you take it as a child, you're set up, ready to break down if you have another one as an adult. And the difference isn't seen for women with just adult abuse. Adult abuse is bad enough, but if you're on top of an abnormal brain, it's very bad. So it's critical development which has stress-induced changes. And it means that there may be types of depressions depending upon whether you were abused before. This is another way of showing the same thing. You see ACTH response, this was interesting. What they did is they took patients and they made them give a speech. You can imagine what my ACTH response must look like now. But a normal response is this. A little bit of ACTH goes up in public speaking. Now if you take this group of people, these were women with early life stress, and they were not depressed. And they have a much bigger response to the stress of public speaking. More so than women who were depressed, but didn't have early life stress. See that? And look at this. These women here are depressed and have early life stress. So the point is, what's bad for your brain is early life stress. And if you add depression to that, you're really in bad shape. But depression without early life stress is probably a different illness. In fact, Nemiroff has shown, this is Christine Heim's work, that if you actually have a patient in your practice that presents to you as an adult who has a history of early life stress, you probably should never take them off an antidepressant. And these are the people for whom psychotherapy works the best. So they probably need lifelong antidepressants and psychotherapy as the ideal treatment. So in other words, then, I'm saying these people need psychotherapy because they're going to get depressed. These people are early life stress, no depression. But that woman is going to get depressed. So you need to help her anticipate that and treat her the first moment she gets depressed. This person is resilient. She has wonderful genes, this yellow line. She probably needs an antidepressant, maybe not psychotherapy. But this is a depressed woman, but no early life stress. This woman who's depressed and early life stress, she needs psychotherapy and lifelong antidepressants because she's going to relapse again if you stop the drug. This is an example of how a good psychiatrist can begin to understand experience related to brain changes, related to atrophy, because this is the same woman who's going to have a shrinking hippocampus. Is this inevitable? Well, I don't think so. One of the things we can do, of course, is do our best to stop children from being abused. The other thing is, did you know that if you have an abuse as an adult and you take a beta blocker right afterwards, it reduces the chances of getting PTSD? It's as though right after the stressor in an adult, your brain learns. And if you could interrupt that learning, it might not go on to get an illness. This is called psychiatric inoculation. Maybe we'll be just like infectious disease doctors. We'll give you a vaccine for your PTSD. And it looks like beta blockers do this, maybe benzodiazepines do it, maybe antidepressants do this. Even the drug Lyrica, Gablin, has been tested for this. If you stop the circuit from learning to become PTSD. See, the circuit learns to have a psychiatric disorder. It's a type of diabolical learning, horrible learning. You've got to stop the brain from learning to get sick. If you can interrupt that memory, boom, you're not sick anymore. If you can reverse that memory, you're not sick anymore. If you can reverse the brain damage from the memory, it allows you to heal. And this is why it takes months for people to really heal from bad mental illness. Even though people say it's 2 weeks or so till antidepressant begins to work. In a horrible case, you know it takes months to recover, sometimes with psychotherapy, because you're reversing the brain's abnormal wiring. And you're trying to get rid of genetic vulnerability and lack of social support by using medicines and psychotherapy as an adult. Because early life stress is a factor for psychiatric illness. If you intervene soon, you have the best chance of helping patients. And this includes reducing every existing symptom you can and preventing the long-term consequences. One of the things you'll find out in a later thing this afternoon is that antidepressants, for example, work very, very, very well for some kinds of anxiety and for most kinds of depression. But for PTSD, it just takes a few symptoms away. It's not curing. So most of us who treat PTSD have to use psychotherapy, antidepressants, and really good sleeping medicines and other things to get all the symptoms gone. And then this idea of if someone has had combat or rape, maybe you should treat them to prevent them from going on. About 25% of people with horrible things get PTSD. We're trying to figure out who those are. You could take other people, like in our country, a famous politician, John McCain. Have you ever heard of him? He's a prisoner of war. He went to a prisoner of war, was 2 years, and never got PTSD. He doesn't have vulnerability, he has resilience. So somewhere in his family history, there's a gene that makes him be able to be resilient. Others of us are vulnerable, and we have to treat people. So are these reversible? Fortunately, yes. Antidepressants not only help mood and anxiety, they make BDNF go up. That's wonderful, because that can help water, garden, and sprout your neurons. Grow them back. Antidepressants may reverse hippocampal atrophy. Do you know that your brain makes neurons in the hippocampus? The dentate gyrus will make new neurons, particularly if the signal goes neurochemically. Stress stops this, antidepressants start this. And here's, if you want, in your handout, messenger RNA content is increased by an SSRI on the middle and by a MAO inhibitor on the right. Antidepressants are increasing the amount of BDNF, which should make your brain grow. If you don't believe me, here's a study of paroxetine patients before and after treatment. And what this shows is in real patients with PTSD, they looked at the size of your hippocampus here, and then they gave you 2 months of Paxil, paroxetine, Cerazide, and they did it again. And the good news is that your hippocampus got 6% increase in size. The bad news, it was only 6%. But let me ask you this. How many in this room wouldn't like to have 6% more in your hippocampus? I would. I mean, I'm getting to be old, so every 1% of my hippocampus I can get, I'd take. So this is probably clinically significant, even if it's small, but it does show the point. And now I'm going to show you, you remember the story of the children of Alice in Wonderland, where she ate the mushroom and then she shrank, and she ate it again and she grew up again? Well, this is Dr. Stahl's slight modification of the Alice in Wonderland story for a psychopharmacologist. Are you ready?
Hello? Is there anyone here?
Absent.
Can I help you, my dear?
How strange. Dr. Stahl, is that you? You look different. What's that you're sitting on?
Well, this one side will make your brain grow larger, and the other side will make your brain grow smaller.
How can that be?
Why don't you give it a try and find out?
Oh no! What's happening to me?
The stress has caused your brain to atrophy.
What am I going to do?
Why don't you try a bite from the other side?
Oh, thank goodness. I feel like myself again. But how did that happen?
Antidepressants can cause neurogenesis and help reduce the effects of stress.
I see. So to alleviate the effects of stress, one can take an antidepressant. Tell me, just out of curiosity, what would one take to treat hallucinations?
So it's not that hard. So in summary, abnormal activity in different brain areas is related to a bunch of symptoms in patients with affective disorders. Many factors mediate the development of affective disorders, including neurobiological and behavioral change, particularly as a result of early life stress. Early intervention is important to prevent or reduce the negative consequences of early life stress. If you understand the underlying causes of neurobiology of the symptoms, it can help you select the best treatments, and we'll be doing that in the next lectures. Post-test, and then we'll go on to Professor Richardson. Number 1, a normal response to stress requires glucocorticoid feedback to the hypothalamus, signalizing the shut off of what? CRF, ACTH, BDNF, A and B, or all? And the answer is A and B, not C, therefore D, A plus B. Very good. Green. Studies have shown that benefits of antidepressants include what? Decreased BDNF, increased CRF, or reverse hippocampal atrophy. What's the right answer? Well, it's not A, it's not B, it is C. Good. And now red comes back. Whoa! And those two put together is green by a nose. So that's the standing so far. All right, ladies and gentlemen, we're now about to have our second lecture, Diagnosing Depression in the Post-DSM Era. And we're going to be talking about the clinical spectrum from unipolar to bipolar. And this is by Professor Elliot Richardson, both of psychiatry and
Toughest thing I think I've ever done.
I got this one this morning, right here. And if you look at his face, it's just ripped to shreds, you know?
You see the movies, you hear the stories, it's... I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost to one of them, you ain't feeling like it nowhere.
So we're going to continue with our program for the third lecture. I'll be giving this one. What's new about combining multiple neurotransmitter mechanisms to attain sustained remission of all symptoms? Your tale is very sad, and I'm almost sorry I took an antidepressant. So, we're going to talk about things that help sadness. But antidepressants don't just treat sadness. They treat the syndrome. Remember, you need at least 5 symptoms to be major depression. There's actually 66 ways in which you can combine the 9 symptoms in DSM and have major depression. But they're not all the same circuits. So it should not surprise you if you have 66 ways to be depressed. Maybe you need more than one way to treat it. 66 or 1, I'm not sure. So our objectives here are to explain that residual symptoms are common outcomes after treatment. Everybody knows you have symptoms before treatment, but most patients have symptoms after treatment. We're going to discuss the implications of allowing those to persist. Some of the new information is on insomnia. This is why we have a lot of talk tomorrow about sleep, but I'm already going to talk a little bit about the problem of allowing insomnia to persist. We're going to identify a number of specific symptoms that are the most common after treatment, because everybody in this room is trying to get rid of all symptoms, not just the easy ones. We will explain how treatments that target multiple neurotransmitter systems in multiple circuits have higher remission rates than single. And if 2 is better than 1, 3 is better than 2 for some patients. We will talk about that. Pretest. Which of the following symptoms is least likely to persist in a depressed patient after 8 weeks of treatment with an SSRI? The least. 1, depressed mood. 2, psychomotor retardation. 3, insomnia. 4, physical symptoms or fatigue. 5, problems concentrating. 6, 1 and 2. 7, 3 and 4. 8, 3, 4 and 5. Least likely to persist.
6, 7, 8. Insomnia. The least.
Go backwards. Oh, this is a very smart audience. Go back, go forward. Okay. Same answers, new question. Which of the following symptoms is most likely to persist in a depressed patient after 2 months of treatment with an SSRI? Same answer. Well, you can go home, you know the answer. After 8 weeks of treatment with any antidepressants, about 2/3 of patients, now wait a minute before this, only about half of you are using keypads, because we know there's 500 people in the room and 250 responses. Please use your keypad. It's been proven that if you touch something, when you learn, you will remember it better. It's called tactile learning. So, please guess on this question. After 8 weeks of treatment with any antidepressant, about 2/3 of patients have a response and 1/3 have remission. True or false for all antidepressants? Uh-oh. This is a trick question. Let me read it. After 8 weeks of treatment with any antidepressant, about 2/3 of patients will have a response. True. And about 1/3 will have a remission. Not true. 1/3 will have a remission on SSRIs, but 1/2 will have remission on SNRIs. So this is a false statement. Next. Maybe you don't believe, I will show you the data. So here we go. What are the most common residual symptoms in major disorder of depression following treatment? In other words, what are the residual symptoms after treatment that prevent remission? And you are very smart. You know that the answer is, if we shine an antidepressant light on this iceberg, we not only get rid of mood and depression, but underneath you get rid of all these other symptoms except fatigue, sleep dysfunction, and executive dysfunction. Okay? So, Dr. Nierenberg studied 8 weeks on Prozac, fluoxetine. How many people had no symptoms? 17%. 17% remission. How many people had one? About 1/4. And the rest had 2 or more. What were the symptoms? Here they are. Suicide went down, very uncommon. Psychomotor retardation, very low. Depressed mood, very low. So the best treatment, the earliest treatment, all drugs, mood, psychomotor retardation, if you have weight loss, it helps that. What are the worst? Insomnia. Way over here. And fatigue. These are terrible. And problems concentrating. Lack of interest in examination. This is a kind of energy or fatigue sometimes. These are the ones that are hard to treat after 8 weeks, particularly with an SSRI. So the reason people are not in remission is because of insomnia, fatigue, and concentration. Fatigue is caused by physical symptoms. This is a study by Baer showing that if you treat with an SSRI for 9 months, very interesting, the core symptoms keep getting better and better and better and better. Better and better and better and better. Positive well-being, better and better and better. Social functioning, better and better and better. Even work activities, somewhat better. But look at this, physical symptoms. They improve for a month, and that's it. The worst thing for SSRIs are physical symptoms. Means fatigue. And other physical symptoms. Fatigue is often caused by problems sleeping. So this is the major reason why people are not in remission with an SSRI even after 9 months. So what are you going to do about it? What is the circuit for insomnia or for fatigue? What are the neurotransmitters in that circuit? And what can I add to fix it? So the least common symptoms are depressed mood, suicidal ideation, and psychomotor retardation. You were right. My residence in San Diego in psychiatry, I say antidepressants are very good anti-sadnesses. They work for sadness. Great for sadness. For the most common, antidepressants are not good for insomnia. Some people get better, but usually this is the least likely symptom to improve. Also, hypersomnia with fatigue, asthenia, weakness, lack of physical energy, lethargy. These are all a cluster of bad symptoms that the SSRIs in particular do not treat well. And also, this is fatigue in your body. This is fatigue in your brain. What do you do? The first thing you could ask, are there any really differences in SSRIs versus SNRIs, or is this a marketing myth perpetuated by the pharmaceutical industry? Shall we take a look at the data? Because there are wars out there with people that say yes and no and argue. Let's look at the data. First of all, the drugs do not differ on response rates very much. No matter what antidepressant you give, most of them will make you have a response. But that's only 50% reduction in symptoms. The difference occurs when you look at remission. And it turns out that about a third of patients have remission on SSRIs, and about a half have remission on an SNRI. But about a half don't have remission on anything. So even the good drugs only work half the time. So today I'm going to do two parts. What's the difference between SSRIs and SNRIs? And the second one is, what do you do when an SNRI doesn't work? Okay? So here's the first part. The famous FACE study suggests that venlafaxine, which was the SNRI, works better than pooled SRIs. This is famous, but controversial. Why? Criticisms. The original FACE meta-analysis suggested superiority of dual action over single action agents. Was this a marketing story or science? They only used one dual action agent. Most of the single data was for Prozac. No citalopram, no escitalopram. In the United States, fluvoxamine is not an antidepressant. Evidently, when you make it in Holland by Solvay and sell it in Europe, it works for an antidepressant. But you put it on a boat and send it to New York and it doesn't work. Maybe it's the FDA. Another issue, this did not exclude patients who were previous non-responders to SSRIs. So this is the criticism of the FACE study. Also, there were 24 other comparisons, and he only published 9. So people said, maybe this is hiding the bad data and showing the good data. So people were suspicious about this. So what happened next? A large study by Nemiroff. It's not been published, it's still in press, but this was the original poster. And now this is 33 studies. Everyone known. And here's the odds ratio. If the line touches this dotted line, it means it's not statistically different. So Prozac, fluoxetine separated because it had a large number of studies. Some of these others did not separate as clearly, but the total for 32 studies did. So this seems to show that there is something about it. Then the company that makes this drug decided to do a small study and showed there was no difference. This, however, has a couple of problems to it. No placebo, small numbers. This is 60. Do you see the numbers of these studies? 3,000. Study here. The THACE study was here. The THACE study is 400, 700, 800. This one here is over 3,000 patients in the NEMROF study. So what I'm saying basically is that you can't tell the difference between two things if you only study a small number of patients. And the other thing is that they dosed venlafaxine very fast, which caused dropouts. There's another one, which is escitalopram versus venlafaxine. The same thing. They show no differences. But this is also a small number, fast dosing of the effexor, and no placebo. So these are evidence against a difference. And it's always interesting that the company that pays wins. If I study your drug, my drug wins. If you study my drug, your drug wins. But what you have to do is look beyond the sponsorship to the data, and it seems to me that if you put all the data together, here's placebo. This is the NEMROF 32 patients, the 32 studies of 3,000 patients. SSRIs and SNRIs of a large number. It looks like it's pretty good, that there is a difference. Now, is that big enough? Do you care? Do you care if it's 45% versus 35%? That's up to you. The reality is, even this one, half the time there's not remission at 8 weeks. So you can do two things. First of all, if you use something like effexor and it doesn't work, raise the dose. If it still doesn't work, use more time. If it still doesn't work, add a different neurotransmitter. And we're going to talk about adding GABA or adding histamine. Okay? But keep effexor as a platform and then add some new neurotransmitter in another circuit. So let's take a look at that approach. Are the superior remission rates in major depression with venlafaxine unique? Or do they work for other dual? In other words, if this is a marketing study, it's just about effexor. If it's a pharmacology study, it's against all dual action agents, right? So let's take a look. Clomipramine, dual action, serotonin and norepinephrine versus SRI, single action. And this is a classical study, better than an SSRI. Duloxetine, new SNRI. It's available in some of your countries. Also shows superiority of duloxetine over SRIs. Milnacipran, French, Japanese, an SNRI in testing in the United States, also shows superior remission rates compared to SSRIs. If you look at adding one NRI, zipramine, to one SRI, fluoxetine, this is better than either fluoxetine or the zipramine with Nelson's famous study. So you can do two drugs together to have two mechanisms, or one drug that has two mechanisms. Every time you have two mechanisms, it's superior to one. So in summary, some individual studies, such as the sertraline and escitalopram studies, do not agree. But most of them show higher remission rates with any dual-acting agent or with two agents put together. The most popular combination in the United States is bupropion with an SSRI. Because a bupropion is, although it's available off-label in many countries and then maybe not be reimbursed because it's only approved for smoking, it's an excellent combination with an SRI that essentially has the same pharmacology as an SNRI, but with two drugs. And we like that because it's superior. But there are many ways to get dual action. The other mystery is some patients will respond to one dual action strategy, and others will respond to a different one, And even though it should be the same theoretically, sometimes patients are different. It's not, that's part of the art of psychopharmacology. But I believe it's fair to say that dual action agents have more efficacy than single action agents. So, the thing you should be looking at to criticize this yourself is the clinical trial design. You need randomized, double-blind, parallel groups. You need to have a placebo. There's this issue, you may know some statistics. It used to be that most of the studies were done with LOCF, or intent to treat. The new ones are done with MMR, mixed model regressions. The mixed model accounts for dropouts. You will see that the new trials use MMR. And this is going to be the standard among regulatory agents at EMEA and FDA. And if you do this, you will find that, particularly if trials are 12 weeks in length, that you will have superiority of dual action. But this is not just about dual action with serotonin and norepinephrine. It's true for multiple examples. And patients may have, like I said, mysteriously a better result from one than another, but it really doesn't matter to me how you do it. You just need to get rid of all symptoms in your patients, however you do it. Some patients are easy, and any drug will make all symptoms go away. I'm not talking about them. You wouldn't be coming to a course and spending a weekend to learn about the easy cases. You're interested in the difficult cases. And we want remission for difficult cases as well as easy cases. And I'm going to next explain different pharmacology. So, let's see what we're going to target. Which of the following symptoms is least likely to persist in a depressed patient after 2 months of treatment with an SSRI? Least. Depressed mood, psychomotor retardation, insomnia, physical symptoms or fatigue, problems concentrating. 1 and 2, 3 and 4, 3, 4, and 5.
لا بعد ما تبدأ الساعة بعدين.
And most of you knew it's 1 and 2, therefore it's 6. Yeah! Woo! Good work! Boom! There's green.
عشان جيت معانا. أول مرة.
Which of the following symptoms is most likely to persist in a depressed patient after 2 months of treatment with an SSRI? Same list.
3 و4. لا 5 كمان.
And the answer is 3, 4, and 5. Therefore, 8. 3, 4, and 5. Whoa! Yes! Boom! Ah, red! Now, blue. It's time to make your move. After 8 weeks of treatment with any antidepressant, about 2/3 of patients will have a response, and about 1/3 will have a remission. Blue, the answer is false. Blue, the answer is false. Don't tell me about blue, it's false.
يبغاهم يفوزوا.
Oh, what's the answer? False! Oh, look at that. Oh, look at that! Oh! I tried. All together. Whoa, it's high in between red and green. All right, so far so good. Next question. augmentation of an antidepressant with a hypnotic in depressed patients, A, robustly improves sleep onset and sleep maintenance. B, significantly improves core, non-sleep, DSM-4 symptoms of major depressive disorder. C, improves remission rates based upon reducing the entire spectrum of symptoms of major depression. A and C, all the above. Go backwards. This will be news to you. Everybody knows that if you treat with a hypnotic, A gets better, right? By definition, hypnotics improve sleep onset and sleep maintenance. No surprise. But what is a new study, very interesting, shows that if you give a hypnotic to a depressed patient, this also improves energy, fatigue, sadness, and there's more remission rates beyond sleep. There is something therapeutic about sleep beyond fixing insomnia. Very interesting. I will show you the data. Next one. By adding noradrenaline reuptake inhibition to 5-HT reuptake inhibition, SNRIs have the following theoretical advantages over SSRIs that could explain their increased remission rates. A, synergistic actions in spinal pathways to reduce physical fatigue and painful physical symptoms. B, prefrontal cortical actions to improve cognition. C, actions at the hypothalamus, sleep-wake switch to improve insomnia. A and B, all the above. No, no, no. Back. The main reason SNRIs are very good, SSRIs are A and B. If you give an SNRI and the patient is not in remission, the major reason will be insomnia. So if you have someone who takes Effexor, let's say, or duloxetine, or whatever, and their mood's better, and their pain is better, and their fatigue is better, and their cognition is better, and they're still not in remission, the probable reason is they still have insomnia. And what you will do for them is add a hypnotic. Okay? Don't switch from Effexor or from whatever they're on, add. Okay? So the right answer here is D. Okay, next one. When SNRIs are dosed to inhibit the noradrenergic transport problem, they simultaneously increase dopamine in prefrontal cortex and are triple action agents, serotonin, noradrenaline, and dopamine. True or false? is interesting. It's true. I will show you the pharmacology in just 1 minute. SNRIs, everybody talks about dual action, dual action, dual action. The reality is in the cortex, they're triple action. And I will show you why. Okay, here we go. Is there any compelling pharmacologic or neurobiological rationale to suggest that multiple neurotransmitter mechanisms enhance the chance for remission? Partly I've shown you SNRI versus SSRI. Now I'm going to go beyond that. Remember, the most common residual symptom in depression is insomnia. When I went to my residency, I was told that good doctors don't treat insomnia with sleeping pills long term. Bad doctors do. You don't give sleeping pills for 30 days. Naughty, 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 bad person. Make them addicted. Then I did an analysis of my practice and of very good psychiatrists and of the prescribing data, and I found a terrible, dirty little secret. People give sleeping pills for 31 days. It's psychopharmacological pornography. Nobody does it, but lots of films are being rendered. Everyone's ashamed to prescribe sleeping pills. But this, any good doctor knew was a good thing, because our job is to reduce symptoms and make remission. And one of the new ideas is that you must treat insomnia as long as you need to treat insomnia, even with a sleeping pill. You can treat it with trazodone if you'd rather. You can treat it with Seroquel if you'd rather. I'm going to show you some very interesting data from an old pill from Europe that came to the United States as S-zobiclone. How many of you have zobiclone in your countries? That's RS. Because of patent reasons, it came to the United States as S. But zobiclone and zolpidem, which we call Ambien, probably cause no dependence. And they can be taken for 12 months. Yes. You never say never, but there's absolutely no data from the clinical trials that they cause it. So that the reality is that the safest agents to use would be Seroquel or trazodone. If you have to give a hypnotic, the safest agents to use are zobiclone or zolpidem. And you have to weigh the risk versus the benefits. Would you rather have a patient who has insomnia or a patient in remission? Would you rather make someone slightly dependent on a sleeping pill? Maybe, rarely. Or would you rather have them suffer? Because what's very interesting is if you allow insomnia to persist, the patient will have another episode of depression. If they get all their depression better but their insomnia, they're going to be sick again. So if you want people to be well, you have to treat insomnia. So hypnotics do make sleep better. But did you know this? The FAVA study is absolutely revolutionizing a great deal of thinking about hypnotics in the United States. This study I'm going to show you has just been published this month in Biological Psychiatry. I'm going to show you the abstract from last year's APA. What he showed was that hypnotics help depression in depressed people. Hypnotics help energy in depressed people. Hypnotics help concentration. Why? Because if you sleep at night, you have energy in the daytime and your brain works. And they increase remission rates. So if you're on an SNRI, let's say, and you're still not better, ask the people about their sleep. And you may need to give a sleeping pill, and you may give it long term. Here's the study. What they did was give people fluoxetine plus S-zobiclone, or fluoxetine plus placebo, for 8 weeks. And here's what they found. Fluoxetine plus S-zopiclone data I'm not showing you helps sleep, insomnia, wake, all that. I'm not going to waste your time with that. But it also helped remission rates at 8 weeks. These were not sleep symptoms that got better. This was mood. This was energy. This was concentration. So remission rates were improved at week 8 by a sleeping pill, by doing more than helping insomnia. So the depression data in this study show that fluoxetine treatment improved depression at week 4 and better at week 8. But if you combine it with a sleeping pill, it had greater antidepressant effect, as demonstrated by improvement of the HAM-D, increased response, increased remission, and significant treatment effects at week 8. Even if you take the insomnia item out. Insomnia pills treat more than insomnia. So the most common residual symptoms are insomnia, and what is your solution? Don't switch the antidepressant. You could add these drugs which are considered non-benzodiazepines, such as S-zopiclone, or in your country maybe zopiclone, or Ambien. There's also, that's called Zolpidem. Indapam's a new one that's testing. Have you seen this drug yet? Indapam is coming as a Pfizer and Neurocrine drug that will be coming shortly. Trazodone is an old friend, very inexpensive, very good drug for sleep. It works by a different mechanism. If you're rich, you can take quetiapine. Very expensive drug, very expensive sleeping pill, but it works. So the issue is, I don't care how you do it, but if a patient has insomnia, I will keep your dirty little secret. If you decide to give a sleeping pill for 31 days, I won't tell anybody. But your patient will thank you. Because this is consistent with the notion. Now we have triple action. We have serotonin, norepinephrine, and GABA. Or if it's trazodone, serotonin, norepinephrine pump plus blocking 5-HT2A. 3 mechanisms in some patients are necessary, rather than 2. If you take an SNRI and still have insomnia. How about fatigue? Remember, physical symptoms of fatigue, tiredness, and pain are also very common. What do? Well, one of the interesting debates and controversies is that antidepressants don't really work for pain. They just non-specifically make you feel better. If you have pain, that feels better too. But if your depression doesn't get better, it doesn't work. This is not true, because the ultimate test of this is what happens to pain when you're not depressed. If pain gets better when you are depressed, is it direct or indirect action? The answer to that depends upon what happens to pain when you're not depressed. So I'm going to now show you studies of pain when you are depressed and pain when you aren't depressed. Because this is one of the most important differentiating areas between SSRIs and SNRIs. Because SSRIs do not work for pain. SNRIs do. So we're going to talk about a specific action. And it is true for multiple SNRIs. Okay? Remember this? This is a bad thing right here. That is what has to be targeted, or you will not have remission in many patients. And that does not get targeted by SSRIs, because SSRIs have a limited effect. So here's a study of venlafaxine versus SSRIs on somatic symptoms, painful somatic symptoms. Placebo, SSRIs, SNRIs. More efficacy. In depression. Is this true just for Effexor? No. It's also true for duloxetine. Placebo, duloxetine, fluoxetine. It's a little slower. It doesn't show up statistically until week 8, but it is statistically better. Here's an interesting thing. Duloxetine asked people who had pain whether they got better on placebo, a little bit, whether they got better on Paxil, not statistically. Low dose of duloxetine, higher dose of duloxetine. In fact, duloxetine probably doesn't work very well until you're almost at 120 milligrams. So those of you who use it should use it at a higher dose in psychiatry. But this also proves the same thing that the venlafaxine slide did, that if you're depressed, your pain gets better with a dual-acting agent better than a single-acting agent. Now the ultimate test is, what if you're not depressed? First of all, this is a preclinical model of politicians rather than humans. I mean rats. Sorry. This is rats. Duloxetine. In a pain model of a rat, it works for pain. Gabapentin, neurontin, it works. Amitriptyline, an old tricyclic, it works. Venlafaxine, it works. No, this rat is not depressed. This rat has a painful paw. So, will it work in humans? One of the models is fibromyalgia. In this study, an SSRI was looking at, and SSRIs don't work because it's too selective. But SNRIs, like milnacipran, do work. This is a new drug, an old French drug, now new in the United States, working in testing for fibromyalgia. How about tricyclics? Amitriptyline is a pain drug. This is the most popular pain drug in the world for chronic pain because it works better than SSRIs. How about venlafaxine? Not depressed patients. Peripheral neuropathy of diabetes. Placebo. Venlafaxine. Tricyclic. And tricyclic and venlafaxine work equal. No depression, just pain. Whoops, duloxetine. Duloxetine was the first drug, this is diabetic, peripheral, neuropathic pain. It was the first drug ever approved for that condition. What's the second one? Pregabalin. So if you have neuropathic pain, most people in the world now are treating with an SNRI, either a tricyclic, venlafaxine, or duloxetine, plus either pregabalin or neurontin, which is gabapentin. Because even though this is improved, it's better than nothing, but they still have pain. So most patients are better but not well. The point is that dual-action agents, 3 of them, all work for pain even when you aren't depressed. So this is the potential explanation of why physical symptoms in depression require dual-action agents to go to remission. So the idea is that your descending spinal spits serotonin and norepinephrine, and if it works, it inhibits, no back pain comes up. But if these don't work in depression, ooh, goes into the brain. Not enough serotonin inhibition, not enough norepinephrine inhibition. What if you have a stomach ache? Normally, you do not feel your digestion. But if the pathways of serotonin is too low, depression too low, norepinephrine, you have stomach pains going into your brain, neck aches, back aches. These are actually interesting phenomena because normally the spinal cord inhibits this information getting into the brain. You may be sitting there, and if your spinal cord is working and you're not depressed, you can't feel your tired bum. You can't feel your aching back. You're not aware of your breathing. You're not aware of your eyes blinking. You're not aware of your digestion. Your spinal cord is saying, don't come into my brain. Don't bother me. I'm listening to this incredible lecture. I have attention on the stage. But if you're a little bored, and the lecture isn't so good, oh, my butt hurts. When's he going to be done? I'm hungry. I got to go make a phone call. Because your spinal cord lets that information. Now, if you're depressed, your spinal cord doesn't work very good. Because your neurotransmitters in your brain don't work, but they also go down the spinal cord. Then all of a sudden you get false information. You feel like you have pain, but it isn't really pain. It's because normal sensations are not being suppressed. And so the patient comes in and they're very sure that their arm hurts, their back hurts, their neck hurts, and they want you to take an x-ray and they want you to find something, oh, I have an ulcer. It's false information. And the reason that the medicines work is they increase the inhibitory tone down the spinal cord. And you need norepinephrine to do that. Serotonin doesn't work so well because they're actually both excitatory and inhibitory serotonin pathways, but there's only inhibitory noradrenergic pathways. Bottom line, if you want fatigue, aches, pains from depression to get better, you have to give noradrenaline. So even if you give an SNRI, you've got to use the dose, because one of the biggest problems of using SNRIs, I think, throughout the world is underdosing. Most people think that 150 milligrams is a dose. That is a primary care physician's dose of venlafaxine. Most people think 60 milligrams of duloxetine is a dose. That's a general practitioner's dose. If you want to be a psychiatrist, you have to be able to dose venlafaxine at least 375, sometimes 450 and higher. Duloxetine, 120, 150. You have to be powerful with dosing to get the norepinephrine effect for pain. So, if you add noradrenergic to serotonergic, you can help fatigue, tiredness, and pain. SNRIs, as I said, even tricyclics. If you want to, you can use bupropion and an SSRI, or you can even use bupropion plus an SNRI. Some countries have reboxetine, some countries have atomoxetine, everybody has dizipramine. There are ways, and even meprodoline, even nortriptyline. Some of these drugs can be combined. It depends on the country that you're in. But there's an old saying, there's many ways to skin a cat, many ways to solve a problem. You need to have solutions that add norepinephrine to serotonin. Lots of different ways. Mirtazapine plus venlafaxine, the so-called, I call it California rocket fuel. If the venlafaxine is not working, dial the dose up. If it's still not working and you have insomnia, give zobiclone. But if you still have problems with fatigue, give mirtazapine. You understand? It's rational because you're taking the symptom that the patient has, thinking about the circuit that doesn't work, and then adding the correct neurotransmitter. You're not just throwing drugs at a patient. Stimulants in the United States sometimes we use. It's controversial. Patients are very sick, particularly elderly patients, we use stimulants. Also some ADHD patients. So many different ways to do this. The last thing I want to talk about is energy in the brain. Problems concentrating, executive dysfunction, mental energy. Now, some of you didn't know the answer to the pretest. Did you know that SNRIs are not dual action, but they're triple action? How is this? Because God did not put dopamine transport pumps in the front of the brain. I don't know why she didn't. I mean, God did not put dopamine 2 receptors in the front of the brain. The cortex is a funny dopamine area. What you want to do in the cortex is increase dopamine at D1 receptors in order to improve cognition. But the funny thing is, if you block a dopamine pump, nothing happens because there are no dopamine pumps there. In the front of the brain, dopamine is not inactivated by dopamine pumps. It's inactivated by two mechanisms. Catechol-O-methyltransferase enzyme and norepinephrine pumps. And I will show you that in a cartoon. So dual action is really triple action because you get dopamine for free in the cortex. And I will show you the cartoon to explain this. Ready? Dopamine reuptake. Dopamine pumps are plentiful in the caudate nucleus, in the basal ganglia, in the nucleus accumbens, in the limbic area, yes, but they are scarce in the front. And remember, the front of the brain is where you want, on the outside, dorsolateral cognition, on the inside, emotions. So if you want to get 3 neurotransmitters in the front of the brain, you need to get dopamine too. But there are no dopamine pumps there, so how are you going to increase dopamine? You have to understand that dopamine in the frontal cortex diffuses away from dopamine synapses to target dopamine receptors, and when it's functioning well, you have good cognition. And this is important, otherwise you have poor cognition. So this is an important part of getting remission. Now, the lack of dopamine reuptake pumps in the frontal cortex indicates that dopamine reuptake inhibitors won't work. You can't block what is not there. Thus, if you have a dopamine reuptake inhibitor, and you may hear that in the marketplace there is this idea of a triple reuptake inhibitor, some new drugs in testing called triples. The triples will work in the caudate, but the duals already work in the cortex for this reason. Dopamine reuptake inhibitors won't work in the cortex because dopamine transmission is enhanced by blocking noradrenaline pumps. Did you know that? The noradrenaline pump has more affinity for dopamine than it does for noradrenaline. And over time, when dopamine comes close to a noradrenaline pump, it sucks it up. And guess what happens? If you have a noradrenaline neuron fire, what happens? It releases dopamine as well, just to help more. So what you want to do is dopamine go widely through the cortex. Certainly it goes into dopamine neurons, but it's going to get taken up into noradrenaline neurons. So what does this mean if you block the noradrenaline pump? Think about it. Noradrenergic pumps are plentiful in the frontal cortex. They transport dopamine and noradrenaline. Thus, if you block a noradrenaline pump, you don't just get noradrenaline increase, you get dopamine increase. 2 for the price of 1. So, blockade of noradrenaline pumps leads to improved noradrenaline and dopamine. A cartoon, are you ready? Noradrenaline at the top, dopamine at the bottom. Here we go. Noradrenaline has a pump on it. Dopamine, no pump. So normally noradrenaline only diffuses a small distance, but then the pump goes, don't go too far away, pump it right back in. vacuum cleaner. But dopamine diffuses until it hits a noradrenaline pump. Normally. Now, what's going to happen if you block this pump? This pump. Boom. Block it with an SNRI. But you have to have the dose high enough to block it a lot. Boom. You get more noradrenaline. Everybody knows this. But what you may not have known before this lecture is if you block the noradrenaline pump, look what happens to dopamine. Boom, it increases. So, in summary, SNRIs have a greater remission rate than SSRIs, perhaps due in part to their noradrenergic actions in the spinal pathways, improving fatigue, pain, and physical symptoms, and in part due to cortical pathways, increasing noradrenaline and dopamine for executive function. Other studies show that strategies to reduce symptoms that can improve remission rates include adding not just 5-HT and noradrenaline, but also hypnotics. Tomorrow we'll talk about the modafinil in the sleep section. This is another secret weapon for psychiatrists. We will also talk during today and tomorrow about adding atypical antipsychotics to SNRIs. So the modern psychopharmacologist is not satisfied with one drug with two mechanisms, or even in the case of an SNRI, one drug with three mechanisms, triple action in the cortex, unless the patient's well. If the patient's not well, you add serotonin, norepinephrine, dopamine, maybe GABA, maybe histamine, whatever it takes to get all the symptoms gone. The point is, reduce all symptoms whenever possible, combining whatever multiple mechanisms are necessary, not only to reduce, but to improve long-term outcomes. Post-test. Augmentation of an antidepressant with a hypnotic and depressed patients. A, improves sleep. Well, yeah. B, improves other symptoms of depression. Or C, improves remission rates. Oh, no. Can't be. Or all three. What's the answer? And the answer is unbelievable. E. Very good. Oh, green. Now, blue, I got a coffee. Come on. Wake up. Little coffee. Almost time for lunch. 2 more questions. We can help you. By adding noradrenaline reuptake inhibition to serotonin reuptake inhibition, SNRIs have the following theoretical advantages over SSRIs. And that could explain increased remission rates. A, synergistic actions in the spinal pathways. They go down the spinal cord to reduce physical symptoms, fatigue, and pain. B, prefrontal actions to improve cognition through noradrenaline and dopamine. C, actions in the hypothalamus to improve insomnia. A and B, all. Well, not C, but A and B. Therefore, D. Yes, very good. Boom! Red! When SNRIs are dosed high they simultaneously increase dopamine in the frontal cortex and therefore are triple action agents? True or false? And many of you knew this, but let's see if the rest of you learned this. This is true. Good! Oh, red, almost perfect. And all put together is red. All right, ladies and gentlemen. Now we're going to have a quick evaluation. I'm going to ask you a question on a 1 to 10 scale. If you strongly agree, 10. If you strongly disagree, 1. Please answer. This course met its objective of discussing the neurocircuitry underlying the symptoms of major depressive disorder. To what extent do you agree? Next question. This course met its objective of reviewing the issues of diagnosing patients across the bipolar spectrum. Do you agree? And thirdly, this course met its objective of showing which symptoms are the most frequently residual after treatment of major depression, and strategies to eliminate these symptoms by combining multiple rational neurotransmitter mechanisms to achieve remission. Do you agree? Oh, no, maybe. Let me ask you this question. I am convinced that treating major depression to remission not only reduces current suffering, but could reduce chances of relapse, as well as prevent neurobiological actions of chronic stress in the brain. Do you agree? I am convinced that all antidepressants have the same efficacy. Strongly agree? Strongly disagree? Are they all the same? Next. I am convinced that combining multiple neurotransmitter mechanisms is a robust strategy for treating residual symptoms in major depression. Do you agree or not? I am convinced that SNRIs have greater remission rates than SRIs in major depression. Oh my goodness, what do you think? Who is paying? Anonymous keypads. You get lunch no matter what your answer is. evaluate the effectiveness of myself in my first lecture on mood circuits on a 1 to 10 scale. Secondly, please evaluate Dr. Richardson's lecture on a 1 to 10 scale. And lastly, please evaluate my second lecture on antidepressants. Is that it? Do you have any more questions? That's it? All right, ladies and gentlemen, we have lunch. Please come back at 2 o'clock. And if you're very good, I'm going to play Dr. Stahl singing Gilbert and Sullivan, little opera. So come back at 2 o'clock and you will hear the song. See you at 2 o'clock.
I know a peaceful spectrum medicine, not just neurological, for hydroponic, polyphosphomatic, moving forward. I'm very well acquainted to matters multi-axial. I understand conditions both the mental and the medical. About substance disorders, I engage with a lot of news. With many triple types of nicotine and alcohol abuse. I'm very good at making diagnoses categorical. I know all of the diagnostic schemes and protocol. In short, in how to mood disorder, exercise and psychosis, I am the very model of a psychopharmacologist. I know psychiatry is Victor William James and pharmacology is a topic of domestic violence. I even debate those who like to say psychiatry is roots. I think every scientologist and little communist. I know all of the mechanisms of our drugs inside and out. It's not a drug available, although which I can be another person stabilizers and meant for anxiety. I've heard about them all attending NEI's Academy. Detail on my full spectrum sequence. In short, it matters mood disorder, anxious type of psychosis. I am the very model of a psychopharmacologist. In short, it matters mood disorder, anxious type of psychosis. He is the very model of a psychopharmacologist. I'm very skilled at making complex concepts obvious simplified. I've structured comprehensive programs that can get you certified. My flawless diagnostic skills have shown me I'm a prodigy. Prodigy? Ooh, okay. Who also suffers from occasional schizophrenia? And if you're wondering about essential psychopharmacology, I'll try to have the third edition done within this century, but still it matters mood disorder, anxious type and psychosis. I am the very model of a psychopharmacologist. It matters mood disorder, anxious type and psychosis. He is the very model of a psychopharmacologist.
All right. Well, a couple quick announcements before we get started this afternoon. We thought we'd make the competition a little more interesting. So we have our team champion competition, and then we'll have prizes for the top 3 keypads for this afternoon. So those that have the most correct answers, the fastest, we have another book that, we have a new sleep book that came out, and the top 3 keypads will each win one of those books from Dr. Stahl. So we'll make that a little more interesting. And so I'll encourage you also to use your keypads throughout the afternoon. One of the reasons that we do that, as Steve mentioned, it's a great way to start to lock down some of the additional learning that you have. And I think with that, we're in pretty good shape for this afternoon. So without any further ado, for our next presentation, please welcome up Dr. Stephen Stahl.
Symptoms of anxiety disorders may be most closely linked to this circuit? Cortical, striatal, thalamic, cortical, sometimes called CSTC. Which symptoms are most closely linked to the CSTC circuit? A, worry and generalized anxiety disorder. B, panic and panic disorder. C, obsessions and obsessive compulsive disorder. D, A and C. E, all of the above. Nope. Let's see the next question. These are the same answers. New question. Which symptoms of anxiety disorders may be most closely linked to the amygdala? Worry in GAD, panic and panic disorder, obsessions and OCD. Yeah. Good. Fear, panic, okay, is in the amygdala. Worry, obsessions, a loop of endless thought is the circuit from cortex to striatum to thalamus to cortex. Now, if your worry upsets you, then you also have the amygdala. But just worry and obsessions are CSTC. CSTC. Fear, panic is amygdala. So let's take a look at some of these circuits. The objectives are to review the neurobiology of fear circuits and contrast that to worry circuits. They're different. And show how the fear circuit could be involved in mediating the affectively upset kind of emotional symptoms of multiple anxiety disorders. And then we're going to explain the clinical features, and I have some cases for you. Little video vignettes. And we're going to look at them in terms of the neurobiology and the overlap between different anxiety disorders. Did you ever wonder why all anxiety disorders respond to the same drug? Why are these disorders so different? The reason is that they all come from the same place in the brain. In one case, you may have catastrophic discharge in a panic. In other cases, you may have steady discharge and generalized anxiety. But it's the same circuit and the same neurotransmitters. And we will learn that the two key neurotransmitters are serotonin and GABA. And Dr. Richardson will be telling you that serotonergic agents and GABAergic agents, alone or together, treat every anxiety disorder we have. So there's tremendous overlap. And in fact, if you ever treat patients, you know that most patients have more than one anxiety disorder. And they may have one disorder for a few months, and then another disorder for another month, and then they get depressed, and then they have GAD, and they have panic. They're more, because it's the same circuit. We're going to review two important genotypes. The modern psychopharmacologist has to know two genes right now. One is the serotonin pump gene, or the serotonin transporter. And we want to review how the genotype of this 5-HT transporter influences the fear circuit and the amygdala. And then we want to show the second one. You should leave here this weekend knowing that psychiatry has two genes that are proven to be important for mental illness. And the second one is the genotype of the enzyme COMT, catechol-O-methyltransferase. And this influences cognitive processing in the prefrontal cortex. Okay? What's that? The panic button. How do you push the panic button? A sensation comes in, a vision, a smell, a sound. And if it goes directly to the amygdala, like the startle response can be visual and it can be auditory, like this. So if you reacted without thinking, it would write to your amygdala, and if this frightened you, this was a response. On the other hand, since I've already done that, and you know I might do it again, this could be filtered through your brain and prefrontal cortex. So now if I go, it doesn't bother you because you have prepared to stop that input by filtering it through the prefrontal cortex so it's not an automatic reflex. And we learn how to do that so that we only react with fear when we need to. Because it is a very costly response. If I frightened you, the perioccipital brain would do one of three things. Fight, stupid doctor, you bother me when I'm trying to listen to your lecture. Flight, I'm getting out of here. Or freeze. So these are motor responses. Fight, flight, freeze. And they come from the perioccipital brain. Hypothalamus. Oh my gosh, squeeze some cortisol out of my adrenal cortex. Some catecholamines out of my cortex, okay? Brain stem. I better breathe fast, get my heart rate up, get my blood pressure up, and get the heck out of there. This is a very costly response. And on top of that, you have an affect or an emotion called fear. I'm feeling fearful while my body is reacting. This is a survival. The problem with mental illness is that people have this when they shouldn't. And this costly response occurs excessively and damages the brain and causes suffering. Let's listen to some ideas about fear. Turn the sound up, please. Hello? Sound. Hello? Hello? Mr. Soundman. Try it again. More. My sound man doesn't work very well. Sorry. Try that again, sir.
Fear, conditioned fear occurs in response to a stimulus that in a previous experience elicited fear. In this example,
let's try it one more time. Are you ready?
Fear can be either conditioned or unconditioned. Conditioned fear occurs in response to a stimulus that in a previous experience elicited fear. In this example, seeing a ghost causes direct stimulation of the amygdala via the sensory thalamus, and symptoms of fear, such as palpitations and sweaty palms, occur. In unconditioned fear, the situation is evaluated cognitively to determine whether or not the stimulus is threatening. Thus, when it is noted that the ghost wears tennis shoes and is therefore not a real ghost, the fear response is inhibited.
So the input to the amygdala is where the action is. It comes from the sensory thalamus to process sight, sounds, smells, etc. It comes from, remember, our good friend, medial prefrontal cortex, the anterior cingulate area, the orbital frontal cortex, sensory, and even memories. And the memory part is important for people who have had trauma, for example, PTSD, because if they have something that reminds them of the trauma, it will cause a reaction in the amygdala. And then the amygdala has outputs, which I've already shown you on the other slide: periaqueductal brain for motor, parabrachial nucleus for breathing, locus coeruleus for blood pressure and pulse, and the hypothalamus for cortisol. And this all relates to the spectrum of disorders. 5 anxiety disorders: social anxiety disorder, panic; obsessive compulsive disorder, GAD; generalized anxiety disorder, PTSD; post-traumatic stress disorder. So I'm going to show you a case, and then we're going to then try to match a symptom with a circuit. Let's listen to Sophie. Sophie is someone whose Polish background, is in the United States, and is going to talk to us about her symptoms.
I don't know if anyone realized what my life was like. I had attack after attack after attack. In a day, I could have had 5 or 6. Left me exhausted, confused. My brain was flooded with adrenaline. And then it went a step further. I developed high blood pressure. I would become very hot. I would be very dizzy. I would sweat enormously. A black cloud would come over my head. And I was fighting with all my being not to lose consciousness every day for 8 years. I was hoping to die.
So if that's all the information you had, what would be your diagnosis? Panic disorder. And what's the theoretical problem with the amygdala? Let's look and listen.
In panic disorder, the amygdala is activated falsely as a sort of false alarm. This triggers a full-blown fear response when there is no threat or reason for this to happen. Thus, autonomic outputs such as sweaty palms, hyperventilation, and racing heart occur in addition to the subjective sense of fear and experiencing of a panic attack.
So this would be a stupid, spontaneous, nonsense, false alarm. But let's listen further to Sophie, because she has more of a story to tell. And just like real patients, she's more complicated than just panic. Let's listen again.
I didn't want to go fall asleep because there was this feeling of falling down in the pit of my stomach, so unpleasant that I would startle in my sleep. Of course, now I know that's when my father came into my room. I learned very quickly as a child that sex was a great way to attract love. That was the only way my father loved me. I was never praised. I was never cherished, appreciated. The only thing I heard was the negative about me. You hear many times how stupid you are and how unwanted you are, and sorry you're not a boy. I was beaten with fists, hands, spoons, umbrella, belts, whatever my mother could find under her hand. I had welts on my back and my legs.
So, if you have a question now, what would you say your diagnosis is? PTSD, right? She has panic attacks, she has panic disorder, but she also has post-traumatic stress disorder from this abuse in her past. So let's look at what might be wrong with the circuit in her brain for this abnormality?
In post-traumatic stress disorder, a traumatic experience is thought to alter the fear circuit and desensitize it. This is indicated here by trauma putting a dent into the amygdala. Once the fear circuit is sensitized, multiple symptoms occur long after the trauma has passed, including re-experiencing the trauma, hyperarousal, and avoidance. Theoretically, these symptoms are perpetuated long after the traumatic experience is over because of enduring changes in the fear circuit that cause emotional memories and emotional experiences to persist and to be triggered inappropriately.
All right, so let's move on to a third kind of a case. Let's listen to this story.
15, I started noticing when I would go to school and go to class that I would get, start getting very warm and my heart would start racing and I would feel this urge to want to leave the room, like I was going to faint. Then I would have stomach distress. I felt like if I didn't hurry up and get to the bathroom, I was going to be in trouble. I couldn't understand it because previous to the attacks, I was real active in school. I was a cheerleader. I went to several events, for the school. I wanted to do whatever I could do, join. I went on dates. I participated in a lot of things. And then I suddenly found myself withdrawing from social events, from being with groups. I didn't want to be closed in a room with a lot of people for fear that this would happen in front of these people. But I went through a spell where I it broke and I began.
So, what do you think's wrong with her? Social anxiety, right? So let's take a look. In panic, you have spontaneous attacks. In social anxiety, you have attacks, but they're all expected.
In social anxiety, panic attacks are triggered in situations where the individual expects something terrible to happen, often in a social situation where one is subject to the scrutiny of others, and especially in situations like public speaking. In such cases, expectations of catastrophic consequences trigger a panic attack. This has the same subjective qualities as unexpected panic attacks and panic disorder, and is thus characterized by sweaty palms, hyperventilation, racing heart, and the subjective sense of fear and panic.
All right, so we've gone through panic disorder, PTSD, social anxiety. Let's listen to Joseph.
I have never enjoyed anything really in my entire life. I'm constantly tensed up. I don't know if you say my muscles are tensed up. I don't know if it's that, but inwardly I'm tensed up. It's like I was driving down the road the other day and a car pulled down in front of me. And I realized then that this feeling is the same feeling, but it's not as short, it's not as much. But that terrible feeling when a car pulls out in front of you, reduce that. And that's what I live with 24 hours a day, 7 days a week.
How about that? That must be generalized anxiety. And this would be not quite so catastrophic, but very chronic.
In generalized anxiety disorder, the fear circuit is chronically and unremittingly activated at a higher level than normal, but not in as catastrophic or sudden a form as would be the case in a panic attack. Thus, worry can create moderate levels of continuing fear output manifested as nervousness, inattention, and multiple somatic symptoms such as pain and headaches.
Okay, and finally, we'll listen to Stephen. He's got a Boston accent, and he starts out sounding like he has one disorder, but he ends up having another. Let's listen.
My first major incident occurred when I was my first year of college at MIT at about 19 years old. And that incident was marked with first starting of panic attacks, really very high level of anxiety, claustrophobic. I couldn't stay in rooms for a test. I had those, running went wrong. Then the obsessive thoughts were starting to come in and out. I really thought it was just something physical in the beginning, because it had physical symptoms to it. My obsessive thoughts at that time, they started to increase, and they dealt with the issues of hurting myself or someone else, especially if I was driving a car, I'd be afraid that I was going to swerve into the other lane and crash into the car.
So obviously, you've got OCD. Now, OCD is not really the amygdala. It's a different circuit. Let's listen to this.
Obsessive-compulsive disorder may use a different circuit for mediating its symptoms than the amygdala fear circuit. In OCD, frontal striatal projections, which relate to the thalamus and then back to the cortex, may be abnormally increased in activity, causing obsessive thoughts and compulsive behavior. The treatment of obsessive-compulsive disorder is aimed at reducing these abnormally increased frontal striatal outputs. Antidepressants that can boost serotonin selectively are all effective in reducing OCD symptoms, since serotonergic projections impinge upon all elements of the circuit and slow neuronal activity there, thus reducing obsessive thoughts and compulsive behaviors.
So what you have is serotonin going to the amygdala, stopping everything that's wrong with the amygdala. GABA is in the amygdala. If you boost it with the benzodiazepine, it helps anything that's wrong with the amygdala. And serotonin also goes to the striatum and the cortex to help the obsessions and compulsions. So let's see if you know this symptoms. Which symptoms of anxiety disorders may be most closely linked to CSTC? Worry, panic, obsessions, worry and obsessions, or all? Best answer.
It's your thing. Do what you wanna do. Can't tell you.
And the answer is worry and obsessions, therefore A plus C equals D. You got C right, but A also. Vote again.
It's your thing. Do what you wanna do. Can't tell you.
Now wait. You might say, Dr. Stahl, why did you have us vote again? You just told us the right answer. And the reason is I have done this course in dozens of cities, in dozens of countries, on 5 continents, and I have never yet had an audience that I just told the right answer give me back 100% correct answers. Let's see if Athens is different. Oh! 6% weren't listening. All right, we got it. I'm teasing. It's hard to know these things. But let's see if we get this one right. Which symptoms of anxiety disorders best answer for the amygdala? Worry, panic, or obsessions? Amygdala. And the best answer is panic. B. There we go. That's good. Oh, red again. And red wins this lap. Okay, pretest for the last half of this lecture. Do you know which gene is thought to regulate emotional information processing in the amygdala? Is it the 5-HT transporter gene, the COT gene, both, or neither? No! Next one. Which gene is thought to regulate cognitive information in DLPFC? 5-HT transporter gene, COMT gene, both, or neither? Maybe, you're right. Okay, let's take a look. After years of studying genes, finally there is agreement on 2 genes finally affecting psychiatric illness. And it's not what we thought. There is no gene for any mental disorder. There's no gene for any mental symptom. There are genes for proteins. Proteins make circuits. Circuits regulate symptoms. So nobody inherits a mental disorder. You inherit a risk for a mental disorder. And nobody has one gene that causes a mental disorder. You may need 40 genes. Or there may be 40 risk genes, and if you have 6 bad copies of any of the 40, plus something in the environment, then you get mentally ill. That's complicated. But this is the same model for bipolar, for schizophrenia, for diabetes, for hypertension. These are complex genetic illnesses which have many genes with small risk. If they add up high enough, you get mentally ill. And we already just know 2 of them. Someday we may be able to take your blood and find out that you have the kind of D2 receptor that if we gave you a conventional antipsychotic, you would not get tardive dyskinesia. So we could save a lot of money and give you the old drugs. But he has the gene for tardive dyskinesia, so we have to give him one of the new drugs. You might have the gene that tells us that if we gave you clozapine, you would get a granulocytosis, whereas you don't. So in you, I wouldn't give clozapine, and in you, I can give it, but I wouldn't have to monitor your blood. This is where it's headed. So let's talk about the 2, because this will help you understand the literature. A genotype means a form of a gene. An allele is a copy of a gene. There are 2 types of 2 genes that make a difference in psychiatry. It's not that bad to learn. Okay, what's the first one? There's 2 types of gene for the serotonin pump. If you care, we call them L and S, long and short. This is the name of it. Why is this important? Because depending on which form you get, it tells you whether you have more risk for a jumpy, hyperactive amygdala, which is not a good thing if you want to have an anxiety disorder. A jumpy amygdala means you're likely to get anxious. So let's take a look. The S are more likely to have hyperactive amygdala. How do we know this? If you put an anxious person's head into a scanner and show them a scary face, their amygdala will light up. And if you've got the S form, it lights up more than if you've got the L form. This, in the future, Professor Soldados will tell us this. He's got this special scanner already made in the department. The 21st century psychiatrist will be a geneticist and a neuroimager. Because what will happen is this. We will go and take this patient over here, and we will take a bubble swab like a criminal today, but this will be mental illness tomorrow, and we will send it to some computer in the sky, which will come back with all the genotypes. We'll get 40 genotypes, and we will know the exact risk that you have. Then the next thing we're going to do is we're going to put you in a scanner. And two things I will do for the two genes today. He's in the scanner. And then what we do is we sew scare face. Have faith. Scare face. And all the time we're measuring his amygdala. And the amount of reactivity that he has will tell me whether or not he already has an anxiety disorder or whether he's at risk. The other thing we will do is we will put him in the scanner and say, let's do a cognitive test. And what the cognitive test is called the NBAC test. And I show you this number, and then I show you this number. And I say, I want you to do the one-back test. So I show you 4, and then I show you 3. And he's got a little thing in his hand, and after I show him the 3, he's got to give me back the number 4. And then I show him 1, so it went 4, 3, 1. And when I show him the 1, he gives me 3. That's a mental task. And if you do that, you will light up ELPFC like a hot button. So this is like a psychiatric treadmill. In other words, the psychiatrists were going to be like cardiologists. The cardiologists have a stress test where they put you on the treadmill, put a cardiogram on, and then they test you and test you and test you and see whether or not the cardiogram changes under stress. Right? We're going to have the same thing, but the difference is going to be you're going to do an NBAC test in a scanner for one part of the brain, because that circuit will be tested, and then I'm going to show you scary faces in the other part, and we look at your amygdala, and that plus all the genes I get back will tell me your relative risk for psychiatric illness, and also it'll help me with drug treatment, because one of the things that could happen is that the information processing in these circuits could get more efficient with treatment. And so what this shows you is that these people over here have less efficient information processing than these people. And I'm going to show you why that should matter to you. Because in the next curve, look at this. You have the stress diathesis model I was telling you about. People with S and L don't have mental illness. They have risk for mental illness. And if you have no stressors, there's no difference in the amount of mental illness they have. If you have one stressor, there's no difference. If you have 2 stressors, there's no difference. But look at this. If you have 3 stressors or 4 stressors, the people with the S are breaking down and getting depressed. So this is the intersection of the wrong gene with the wrong environment. And if you have enough bad genes and a stressful enough environment, you break down. And you can measure that by both measuring the gene directly, by the 5-HT pump that your grandmother gave you, and also the stress test in the scanner by looking at a scary face. Another way is this. Has anybody been to San Francisco to the Golden Gate Bridge? Yes. Do you think that if one of the struts broke, that the bridge would fall down? No. You probably have extra ones, don't they? One of the struts is like one of your genes. Do you think if you have one bad gene, you're going to break down and get mentally ill? No. 2? How about 2 struts on the bridge? 6? 6? How about 7 in a truck? How about 8 and a semi? At some point, enough weakness in the genome with enough stress on it is going to make you fall apart. And that is the modern hypothesis of mental illness. The load of your genetic risk, all your genes put together, there's 30,000 of them. Maybe you have to have 10 or 12 bad ones. plus the load from your environment. Shall we take a look at the bridge and see how the bridge tells us about psychiatry? Here it goes. Perfect bridge. Light load, no problem. Heavy load, perfect. No problem. Oops, there goes your 5-HT gene, light load, no problem. There goes your COMT gene, light load, no problem. There's a truck, a little bit of a problem. Dysbinded, neuroregular, 6 other genes done, no light load, no problem. 17 genes wrong in a truck, oh my God, I'm mentally ill. Maybe. So this is the modern idea of the complexity of psychiatric illness. So let's take a look at it this way. The LL genotype makes you have more copies of the serotonin pump, less synaptic serotonin. It leads to less activation of your amygdala and a lowered risk of an affective disorder. Now, if you have one of the S copies, it decreases the number of pumps that your brain makes, which increases the serotonin in your synapse, leading to more amygdala stimulation in the scanner and an increased risk of affective disorder. All right, that's gene number 1. The second gene you have to know is COMT. This does not affect cognition, but it affects your ability to activate DLPFC in a scanner, just as I said, while doing a cognitive test. And there are 2 types of COMT, and they influence cortical processing of cognitive information. Some people call that endophenotype. Phenotype means description, such as blue eyes or schizophrenia. Endophenotype means something intermediate between the disease, schizophrenia let's say, and the gene, COMT. So the endophenotype is the circuit activation in a scanner. And COMT predicts whether you have a hot scan or a cold scan. Let's take a look. The COMT gene has this one place in it that if you change one amino acid from valine to methionine, it makes a 400% change in the enzyme activity. Why do you care? Because the methionine has only 25% of the enzyme activity of val-val. Well, think about it. If you had a choice, would you want more dopamine in your frontal cortex or less? More. Okay. So would you rather have a high enzyme that eats it all up or a low enzyme that doesn't? Low. In fact, people are looking at COMT inhibitors to maybe make you smart. Look at this. Remember what I said this morning, the prefrontal cortex has few dopamine transporters. Thus, if you inactivate dopamine in prefrontal cortex, it's more dependent on the COMT enzyme that you have. I already told you this morning that the second thing is dependent on is the norepinephrine pump, remember? So, if you have high COMT, you have low dopamine. If you have low COMT, you have high dopamine. Who's smarter? These guys. In fact, in this room, there are these genotypes, and we could do a scanner on everybody in this room, and the people who had MET would have to work less hard in the scanner on the treadmill than the people who have val-val, even if they make no mistakes. So this has to do with the efficiency of information processing. In other words, do you know what the brain really is trying to do? It's trying to tell signals from noise. Okay? For example, the signal that you have now is Dr. Stoll talking. The noise that you have is that you have to go to the bathroom, that you want to have a cup of coffee, that you want to go home tonight, that you are worried about your taxes, that your daughter is yelled at you last night. those are all noises. So if you have good dopamine, all that noise is there. There's Dr. Stahl trying to talk to you. Noise, 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 noise. Kick up your dopamine. Think of nothing but Dr. Stahl. Boom! Here, let's show you this one. Go past this one. Noise, signal. Noise, signal. Increase your dopamine, and the signal goes up. And everybody's brain has to do that, or you can't pay attention to what you want to pay attention, and therefore you can't learn. So really what this other data was, I skipped over, it shows you, for example, that people with schizophrenia have bad performance on a cognitive test. This is the Wisconsin card sorting, no matter what kind they have. But the val-vals are worse than the met-mets, and that's also true for controls and for siblings of schizophrenia. The good news is this is a solid genetic finding. The bad news is only 4% of the answer. Only 4% of the variance of schizophrenia is explained by this. Unfortunately, we still have 96% to figure out yet. But we're working on it. So the point would be 2 genes are important in schizophrenia. In this case, low COMT, high dopamine, better tuning of the cortex, more efficient cognitive information processing, and you're more likely to have normal cognition and less likely to have schizophrenia. However, if you have high COMT, you have lower dopamine, and you have less good tuning in your brain, which leads to less information processing and more likely to be in the family or affected with schizophrenia. So in summary, you should now be able to feel confident in reading the literature, because if you see about the genotypes of the 5-HT transporter or the genotypes of the COMT enzyme, you know that these are the 2 most important genetic findings in psychiatry, and that the amygdala is the key component of the fear circuit, and if you have abnormal activity there, you will be able to have many anxiety disorders, depending upon how abnormal it is, and that genes code for important proteins, such as the serotonin pump and the enzyme COMT. And if you understand the neurobiological basis of these things, they can empower you to recognize important symptoms. And I think this gives you rationale to understand what Dr. Rich is going to talk about next, which is he's going to then try to fix the sick amygdala by throwing serotonin, GABA, or both onto them. And that makes perfect sense. So let's do a pose test. Which gene is thought to regulate emotional information processing in the amygdala? Do you remember? Is it the COMT, the 5-HT, or both, or neither? And the answer is the serotonin transporter gene. Hey. Good! Oh my gosh, blue! Oh my gosh, blue! Thank you! How about the gene for cognition? 5-HT or COMT, you know? This is the one linked to COMT. Good! Whoa, red comes back. Okay, the score so far is red a little bit, but blue's in second place. Okay. We are now going to get practical and have our last lecture of the day, and after that we will have questions. Dr. Richardson is going to talk to us about how you apply this circuitry and make a treatment for anxiety disorders.
Okay, thank you. The benzodiazepines are considered the first-line treatment for anxiety, and as such, they constitute the most prescribed therapy for anxiety. C, antidepressants are considered the first-line treatment for anxiety, but the current treatment trends show they are prescribed less than the benzodiazepines. And finally, D, benzodiazepines are considered the first-line treatment for anxiety, but the current treatment trends show they are prescribed less than antidepressants. Mark your key passes. Very good. Very good. Okay? Which of the following statements is true? Antidepressants often are faster in onset and need lower doses for anxiety disorders compared to major depression. B, like their use in the treatment of major depression, antidepressants have most of their therapeutic efficacy in generalized anxiety disorder by 8 weeks of treatment and have only slightly increased remission rates after that. C, antidepressants work less robustly in panic disorder, GAD, and social anxiety disorder than they do in major depression, that is lower remission rates for all symptoms. Or D, antidepressants work less robustly in PTSD and OCD than they do in major depression. Very good. Long-term effects of antidepressants on relapse rates in anxiety disorders are generally as well studied in anxiety disorders as they are in major depression. True or false? Very good. That is correct. Okay, now to the objectives. What I'm going to present is some evaluation of the available treatments as monotherapies for individual anxiety disorders of the spectrum that we talked about, Dr. Stahl talked about. I'm going to discuss a little bit about the combinations of drugs and other treatments such as psychotherapy, brain stimulation, and surgery for the treatment of resistant cases, and demonstrate the goal of treatment is remission of all symptoms, and that this may be accomplished by targeting specific neurotransmitters, especially those that Dr. Stahl talked about, serotonin and GABA. So here again, you've seen this slide before. Dr. Stahl presented the spectrum of anxiety disorders, social anxiety disorder, SAD, panic, obsessive compulsive disorder, generalized anxiety disorder, and post-traumatic stress disorder. So what are the options for treatment of panic disorder? Well, on the one hand, you can take the psychosocial approach, various forms of therapy such as exposure therapy, cognitive therapy. And on the other hand, one can take the pharmacological approach, although these are not mutually exclusive. You can combine these, and we often do. So with respect to the pharmacological treatment, getting the GABA system, we have the benzodiazepines. Getting the serotonergic system, we have the serotonin reuptake inhibitors, as well as the serotonin and norepinephrine reuptake inhibitors, and the anticonvulsants as well, some of which impact the GABA system. So what are the data? This is evidence-based use of these drugs in the various disorders, beginning with panic disorder. And here are some data from a controlled trial with venlafaxine versus placebo. And as usual, placebo is very good at treating most psychiatric disorders, but the active drug is even better in long-term follow-up. What you're going to see is that with a number of these anxiety disorders, longer is better in terms of response and remission rates, particularly remission rates. Another study, in this case with escitalopram in panic disorder, 10-week study, placebo-controlled, escitalopram versus the racemic mixture of citalopram at endpoint. Both active drugs here are separating from placebo. So evidence for efficacy of this serotonin transport blocking drug in treatment of panic disorder. If you look at a number of studies of serotonin transport blocking drugs, in this case fluvoxamine, paroxetine, sertraline, and fluvoxamine, across a number of studies looking at panic attacks. These are the percent of patients who are panic-free at endpoint. Although some of these drugs might stand out, in general, it's not considered that any one of these serotonin transport blocking drugs is better than another. But you notice that the percentage of patients who are panic-free doesn't go beyond 50%. As with depression, all of these anxiety disorders are recurrent, and we want to treat the acute problem, but we also want to prevent the recurrence of the illness, and we want to prevent relapse. And these data here with sertraline are showing just that. With prevention of relapse and panic disorder over a 28-week study versus placebo, at endpoint at 28 weeks, what is seen is about 90% of the patients remaining on the active drug are panic-free versus about 65 to 70% who are on placebo. So strong evidence for prevention of relapse panic disorder with this particular drug. So here is the general use of the whole gamut of drugs that we have available. This is the top 10 drugs that are used to treat panic disorder. If we look at the benzodiazepines, alprazolam is at the top. We have also clonazepam in the yellow here, 13%, and paroxetine in the center here. So if you add it all up, and most of you knew the answer to this, that although antidepressants are considered the first line, most of us are using the benzodiazepines to treat panic disorder. So, if you're using benzodiazepines as well as serotonin transport blocking drugs, what about the combination? You know, oftentimes, in particular in panic disorder, you start a patient on the serotonin transport blocking antidepressant and their panic or other anxiety gets worse before it gets better. So why not combine a benzodiazepine with a serotonin transport blocking drug? And this is what is being shown here. It's an interesting study. In the initial part of the study, there's the combination of sertraline, serotonin transport blocking drug, with clonazepam, the benzodiazepine. But the clonazepam, the benzodiazepine, is not kept for the entire length of the study. It's tapered at 5 weeks. You see an earlier onset of effectiveness in treating a panic disorder compared in the combination compared to the serotonin transport blocking drug by monoamine oxidase inhibitors these days. And I think you only, in Greece, there's only one maclopamide, but the mainstay, again, are serotonin reuptake inhibitors, or serotonin norepinephrine reuptake inhibitors, and beta blockers. Here are some data for venlafaxine in treatment of social anxiety disorder versus placebo, separating from placebo at week 2 or 3 here, and maintaining that improvement versus placebo through 12 weeks of the study. Another study looking at the difference between active and placebo, going out to 12 weeks, showing a steady improvement occurring and seems to be going up beyond the usual time frame that we see in antidepressant therapy. So taking longer to get the effectiveness in the anxiety disorder than we would see in treatment of depression. Paroxetine in social anxiety disorder, separating from placebo at week 1 and maintaining that effectiveness throughout the study up to 12 weeks. Paroxetine and venlafaxine, no difference here. Sorry, misstated that. Paroxetine and venlafaxine equally effective in social anxiety disorder. And actually, venlafaxine separates at week 1 from placebo and maintains that throughout the study. Preventing relapse as well in social anxiety disorder is important. What this graph is showing is the number of patients, or the percentage of patients who are looking at social anxiety disorder and the Leibowitz social anxiety scale to the serotonin transport blocking drug, the serotonin and norepinephrine reuptake blocking drug. Are there augmentation strategies that we can try to get patients into remission? Well, olanzapine is one that's been studied quite a bit, and this is an augmentation strategy. Patients been on, the group of patients have been on a serotonin transport blocking drug, and they've got either a partial response or failed to respond, and they've been augmented here with olanzapine in the range of 5 to 20 milligrams per day. Looking at a couple of different scales in patients who were randomized to placebo versus olanzapine, clearly gabapentin versus placebo. This is not an augmentation strategy, but a placebo-controlled monotherapy trial. And what you see with pregabalin is that it doesn't seem to work at 150 milligrams per day, but at 600 milligrams per day, very clear separation from placebo as well as the 150 milligrams per day, starting at week 1 and out to 10 weeks of this trial. What about generalized anxiety disorder? What are the options? Well, again, on the one hand, we have the psychosocial approach, and on the other hand, we have the pharmacological approach and the same drugs. No surprise, benzodiazepines, serotonin, and norepinephrine reuptake inhibitors, serotonin reuptake inhibitors, and buspirone. Today is not effective versus placebo, whereas the 600 milligrams per day is and is as good as treatment of generalized anxiety disorder, placebo-controlled trial, separating apparent continued response and remission at 8 weeks. It seems to be going up between 6 and 8 weeks. Look what we have here. So again, we have to treat anxiety disorders longer than we treat depression to get remission, but we're still in generalized anxiety. And these are the ones that are remitting, going up 6 months. Now we're achieving in this study over 50% remission rates, remission, complete absence of any signs or symptoms, and the response without remission goes down. This is because the folks who were in this group, the response group, are converting over very likely into the remission group, and that's why this is going down. Various degrees of anxiety, moderate to severe anxiety, and it's a placebo-controlled trial. And here are the data for placebo. Whoa, you see really nice separation from placebo. Again, this would, if we take it out further in the study. What about long-term? So that was randomized at that point, and patients stayed pretty much about the same as they were on the open phase of the study. When they were switched to placebo, the active drug paroxetine, look what's happening. Again, long-term increase in the response to remission, and again, that's a lesson in terms of what we need to do to treat our patients with anxiety disorders. Longer, again, the benzodiazepines have the lion's share of the total prescriptions for generalized anxiety disorder. Paroxetine is up the top of the list. That's the top 10 drugs there. And somewhat similar to what I showed you earlier for panic disorder. But for long-term treatment of generalized anxiety disorder, we want to make sure we get our patients well, and only about 25% of patients have relapse 1 month after stopping treatment, so we don't want to stop the treatment. At 1 year, 68 to 80% relapse within the first year after stopping treatment. So it's a high relapse rate in generalized anxiety disorder, very high. So the lesson here is that we want to treat, as with any recurrent illness, prevent by long-term treatment with the active drugs. The other thing with generalized anxiety disorder is that it is often comorbid, steadily improved for more than 6 months. Longer is better. Remission is the goal. It's the goal of all the psychiatric illnesses we treat. Remission, as with depression, remission is the goal in panic and generalized anxiety disorder. But remission is delayed, and particularly the patients with severe. On the other hand, again, the serotonin transport blocking drugs, tricyclic depressants, and anticonvulsants, monoamine oxidase inhibitors. The data put together from several studies with the serotonin transport blocking drug, to which was added olanzapine. The placebo, 20 milligrams of placebo versus 15 milligrams of olanzapine. Have to figure that one out. In terms of improvement, the olanzapine time, highly comorbid. Interestingly, of all the anxiety disorders, highest rate of suicide attempts are seen in post-traumatic stress disorder patients. It's treatable with serotonin reuptake inhibitors and perhaps other antidepressants and anxiolytics. Obsessive compulsive disorder, psychosocial and pharmacological. The main drug, major drug, at least in the United States, is clomipramine, but the serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors work as well. I'll talk a little bit about some of the physical approaches that are beyond the pharmacological and psychosocial, namely cingulotomy and deep brain circling, fluoxetine, omeprazole, and paroxetine, improvement in the Yale-Brown obsessive-compulsive scale at endpoint. For all drugs, no really difference among the drugs in terms of CD over what is seen with the serotonin transport blocking drug when one augments with olanzapine, in this case between 5 and 20 milligrams per day. So that is a way to go. Use an antipsychotic medication to treat the anxiety disorder. So you augment with the atypical antipsychotic drug. Expect that the atypicals more frequently to be used in PTSD and OCD and other anxiety disorders because slowly increasing the dose. You have to talk to the patient about adverse effects. Here it states about tardive dyskinesia, which fortunately with the newer generation atypical drugs, they're called atypical because they're less likely to cause these problems. But there's another thing that we need to talk to them about, and that is what I'm going to talk about tomorrow morning, namely the metabolic side effects, the weight gain and so forth. And consider tapering the atypical drug. Another approach, which is more recent and an interesting approach in psychiatry, not only for OCD, but for refractory depression, is deep brain stimulation. Now, deep brain stimulation has been used for quite some time now in treatment of Parkinson's disease, to deal with the tremors of Parkinson's disease. It is a surgically implanted, battery-operated device that delivers electrical stimulation to targeted areas of the brain. And this is generally in the basal ganglia or the thalamus. It's an effective treatment for movement disorders, as I stated, in terms of Parkinson's disease, very commonly used these days. And the recent data, a year ago, Helen Mayberg, University of Toronto, who's now at the Emory University in Atlanta, published a series of cases, about half a dozen or so, where deep brain stimulation was used to treat depression. 3 months post-op in the blue and 10 months post-op in the green. And what you see is a complete loss at 10 months of any problems in the compulsions in terms of neglected in the treatment of anxiety. So you combine CBT with a pharmacological approach. Patients who taper drug after long-term treatment may remain symptom-free longer than patients who taper after just a few months. And novel treatments for anxiety include new approvals for drugs like venlafaxine, escitalopram, pregabalin, and there are pending approvals for other drugs such as duloxetine, and there are new data out on deep brain stimulation. However, long-term data are scarce, not as well studied as with antidepressants, so more studies are needed. Okay, post-test. Which of the following statements is true? A, antidepressants are considered the first-line treatment for anxiety, and as such, they constitute the most prescribed therapy for anxiety. B, benzodiazepines are considered the first-line treatment for anxiety, and as such, they constitute the most prescribed therapy for anxiety. C, antidepressants are considered the first-line treatment for anxiety, but the current treatment trends show they are prescribed less than benzodiazepines. D, benzodiazepines are considered the first-line treatment for anxiety, but the current treatment trends show they are prescribed less than antidepressants. Mark your keypads. C. I think most of you got that right last time, and a little improvement from that. Very good. Hey, Red's doing very well after lunch. Okay. Which of the following statements is true? A, antidepressants often are faster in onset and need lower doses for anxiety disorders compared to major depression. B, like their use in the treatment of major depression, antidepressants have most of their therapeutic efficacy in GAD by 8 weeks of treatment and have only slightly increased remission rates after that. C, antidepressants work less robustly in panic disorder, GAD, and SAD than they do in major depression. And D, antidepressants work less robustly in PTSD and OCD than they do in major depression. Mark your keypads. Yes. And very good. Very good. And okay, next. Long-term effects of antidepressants on relapse rates in anxiety disorders are generally as well studied in anxiety disorders as they are in major depression. A, true, B, false. Mark your keypads. You were very good at the beginning on that. Bit of improvement. Excellent. And is it red again? By indeed, by a nose. And for the total, it is the red team. Congratulations.
All right, that was for that lap. We haven't yet announced the winner for the whole day yet. So before we do that, we'll do some quick evaluations, then we'll come back and declare the winner and give away our books to the top 3 keypads. So if you would grab your keypads and insert this course, then its objective of discussing the circuit's underlying anxiety disorders and the genes that control these circuits. And go ahead and punch your response, strongly agree or strongly disagree. All right. Next, this course then its objective of discussing updating you on the sum of new treatments for these various anxiety disorders. Go ahead and punch in your response to that, please. And our next one, I am convinced that SNRIs and SSRIs work across the anxiety disorder spectrum since they all act on serotonergic regulation of the final common pathways of these disorders, especially the amygdala and prefrontal cortex. How do you feel about that one? All right, the next one. I am convinced that the various SNRIs and SSRIs have more or less the same efficacy in anxiety disorder. Go ahead and punch in your response.
have referred patients for deep brain stimulation. Have you had an opportunity to do that? A, yes, B, no. All right. Next. So please evaluate the effectiveness of Dr. Stahl for the anxiety circuits. How many different ways can the same circuits malfunction to cause all the different anxiety disorders lecture, which was his first lecture this afternoon. All right. And then, of course, next. Please rate the effectiveness of Dr. Richardson for the advance in treatment of anxiety disorders. Do SSRIs and SNRIs work for all the anxiety disorders? And if so, why? Which was the lecture you just heard. All right. Do you have one more? Yes. Participating in this course utilizing audience response keypads is a better way to learn than traditional lectures. How do you feel about that one? All right. Next one. I would like to attend another psychopharmacology course utilizing this instructional design, which means participant focus, keypads, animations, case-based learning. How do you feel about that? All right, next one. The information in the program today was unbiased. How do you feel about that? All right. Next. Today's Academy has given me information that I can immediately apply to my practice. How do you feel about that? Go ahead and punch in your response. All right. I think that's the last one. So the grand prize winner, the winning team for the entire day, the red team. Just edged out the green team. The red team wins. All right. The red team has your prizes. Just sit right there. They're about to hand out your prizes. So let them do that. And also look down at your keypads. And on your keypad there's a number. And we're about to award the top 3 keypads for the day. So who has keypad number 116? Raise your hand if you get keypad number 116. 116. Right down here in front. All right, very good. How about keypad number 256? Who has keypad 256? Who has keypad 256? All right. Give them a round of applause. Excellent job today, gentlemen. All right. Congratulations. Then we'll have Dr. Stahl and Dr. Richardson come up for questions.
If any of you have questions, Dr. Richardson and I will take that. I think there's microphones. And you're welcome to ask what you like. Who's got the microphone here? Anybody? Does anybody work on a microphone? This gentleman's got a question here.
Rest.
In New York, Chicago, and San Francisco, and you can see the months of the year that they'll be held up there on the screen. And then our big annual Congress will be in Orlando in November on the 2nd through the 5th. So make a trip over, come join us for our Congress or one of our academies. We'd love to have you there. For today, this morning,
Non-premium lot. Some drink it because they're responsible. What? Others just love the taste.
so our competition today will actually be the men versus the women. So if you'll grab your keypad.
I'm going to be talking about a very important issue, and if you saw the video just a few minutes ago, it highlighted the important points that I'm going to be talking about today. Also, as before, not all of the slides that are in your handout am I going to show today. So I'm going to be skipping over some slides, but you have them in your handout. So let's begin. And the key points today are identifying the treatments and documenting the efficacy in different phases of bipolar disorder. Number 2, identify the agents that can be rationally combined in the treatment of bipolar disorder based on efficacy data and mechanism of action. Number 3, discuss dosing tips and pearls for the first-line mood stabilizing treatments. And as always, we have a pre-test question. Which of the following has been demonstrated to reduce risk of suicide? Is it A, lithium, B, olanzapine, C, lamotrigine, D, A and B, or E, all 3 drugs? Punch in your keypads, please. Okay, well, there's a little learning to do there. Next. What is a, do we have another question? Pre-test question? Right, what is a mood stabilizer? Is it a mechanism of action? We have many different classes of drugs that are considered mood stabilizers. We have the atypical antipsychotic drugs, we have lithium, we have the anticonvulsants. The Food and Drug Administration in the United States doesn't recognize that as a class, mood stabilizers. But, in fact, mood stabilizers are what we know. Various classes of drugs represent mood stabilizers, and they are drugs that are used to treat any of the phases of bipolar disorder, to stabilize the mood. So it is a mechanism of action encompassing several different classes of drugs with several different apparent mechanisms of action. Now lithium's the mood stabilizer that's been around for centuries, and back in the 1940s in Australia, the psychiatrist Dr. Cade accidentally discovered lithium to be an anti-manic drug. It's still used today, but it's a very effective drug, and as you'll see in a moment, that's extraordinary data in terms of preventing suicides with lithium. But clearly it's got established efficacy in treating mania and documented to reduce the suicide risk. I'll show you Dr. Baldessarini's data on that in a moment. But there are clear disadvantages to it. It has a narrow therapeutic index requiring careful monitoring of plasma lithium levels, but in addition, because of the potential adverse effects,
we have to be baseline testing for thyroid function, for kidney function. In recent years, I've seen some rather bad cases of kidney failure associated with long-term lithium. So you have to watch that with treatment with lithium, but it's still a wonderful drug. There are problems, pharmacokinetic drug interactions with lithium in terms of clearance. It has a slower onset of activity compared to atypical drugs as an antimanic. It may have effects on the developing fetus, and there are problems with fluid electrolyte balance in patients who are taking lithium. So it's not all that friendly a drug to use, but it is a very effective drug. Now here are the data that I talked about, and you missed this in the question. It is, in terms of all the mood stabilizers we have, the clear-cut result that Paul Deserini published back in 2003, the enormous reduction in suicide associated with the use of lithium. I don't know that this is statistically different from the general population, but it looks as though it even reduces it below what you see in the general population. But clearly, without lithium versus lithium, a dramatic difference in risk of suicide, and that's a real plus. We have pretest. Okay. Which of the following has the best evidence of efficacy as monotherapy in bipolar depression? And this relates to a question that was asked yesterday on this side of the room. Is it A, aripiprazole, B, olanzapine, C, quetiapine, D, risperidone, or E, ziprasidone? Punch your keypads, please. Okay. All right, what are the data? What is the evidence that antipsychotic drugs can be used as monotherapy in acute mania? Well, basically all the antipsychotic drugs versus placebo are effective anti-manic drugs in acute phases of mania. There is, for every drug, a placebo-controlled study, and for every drug, except the case here, one for quetiapine doesn't quite make it versus placebo, but there are others that show quetiapine to be effective versus placebo. So these are all anti-manic drugs. Acute phase of mania, no different from the old-line antipsychotic drugs to treat acute mania. What about monotherapy for treatment of bipolar depression? Well, the best data to date are with quetiapine, and this is a placebo-controlled study at 2 different dosages of quetiapine, and it is effective versus placebo at both the 300 milligram, we'll just go back to that in a moment, at both the 300 milligram per day and the 600 milligram per day doses. Again, monotherapy for treatment of bipolar depression. We also have recently marketed in the United States OFC, the olanzapine fluoxetine combination. And what are the data for that? Well, this is a placebo-controlled study looking at, again, bipolar depression. This is olanzapine by itself, but the combination is even better. Even though olanzapine separates from placebo by itself, the combination of olanzapine and fluoxetine is even better in terms of treating bipolar depression. So we have that drug in the United States. It's marketed under the trade name of Symbiotics. Ziprasidone, another of the new generation antipsychotic drugs, also has efficacy for treating bipolar depression. Pooled studies versus placebo, not a lot of subjects, 4 in placebo, 18 in ziprasidone, but nonetheless, clearly a signal here that ziprasidone is effective in treating bipolar depression as well. Another pretest. How many risk factors must be present in order to diagnose the metabolic syndrome? Punch or keep it. Very good. Okay. I'll define in a few moments, for those who don't know, what metabolic syndrome is. We have all these new generation antipsychotic drugs. Are they all created equally? Sorry, there's another pretest question. I got ahead of myself here, sorry. As a psychiatrist, if you had just one blood test, you could order to tell you if the atypical antipsychotic drug that the patient was on was likely to increase the risk of metabolic syndrome, which would that be? Which one would you get? Would it be fasting glucose? Would it be the hemoglobin A1C, total cholesterol, LDL cholesterol, HDL cholesterol, fasting triglycerides, or is there some other test you might get? That's the pretest. Punching your keypads. Well, there's a whole lot of learning to do here. You're going to learn something interesting, because most of you got that wrong. Okay. As I was saying a few minutes ago, we have all these new generation antipsychotic drugs. We're using them to treat schizophrenia, of course, but we're also using them to treat mania, and we're using them in maintenance therapy of bipolar disorder. They're mood stabilizers. Are there differences among them with respect to adverse effects, and in particular, the likelihood that they're going to cause the metabolic syndrome in our patients? Well, the available data do suggest that some of these drugs are better than others. And these are data, pooled data from a number of studies, and in this case, looking at weight gain at the end of 1 year of therapy. And one drug seems to stand out beyond all others, and that's olanzapine. The data, and I'll show you some data in a moment from the Katie study in the US, support 2 drugs as being the best with respect to preventing the metabolic syndrome, or certainly not increasing the risk of the metabolic syndrome in our patients. And those 2 drugs, actually, not enough data here for this study, but it's the ziprasidone and aripiprazole. They seem to be weight neutral, and they in fact are in other data. The important thing about the pharmacotherapy with these newer generation antipsychotic drugs that cause the weight gain is that the weight gain, the metabolic syndrome, is reversible. So if you have a patient on a drug such as olanzapine, they gain a lot of weight, they become pre-diabetic, diabetic, you can reverse that by switching the patient from a drug like olanzapine to a drug like ziprasidone or a drug like aripiprazole. So let's see what happens when in fact you do that. This is a 58-week study. Patients have been switched either from conventional antipsychotics. They've been switched from conventional antipsychotics, where to ziprasidone, no change really in weight. The conventionals, things like haloperidol, generally not a problem with respect to weight gain. But look at this. Risperidone, which can cause lots of problems in terms of weight gain, switching from risperidone to ziprasidone. Nice loss in weight over the 58-week period of time. And even better when patients are switched from olanzapine to ziprasidone. So if you have a patient who's gotten overweight, has the metabolic syndrome from being on risperidone or olanzapine, switch them to ziprasidone. Likewise, if they've developed the metabolic syndrome, become overweight on olanzapine or risperidone or quetiapine, switch them to aripiprazole. And no matter how you do it, whether you switch immediately, take them off one drug, start aripiprazole, or you taper the current antipsychotic, put them on aripiprazole, or you up-titrate aripiprazole and off-titrate the other antipsychotic. No matter how you do it, the end result is a loss in weight, a loss of the weight that the patient gained on the other antipsychotics such as olanzapine, quetiapine, or risperidone. So this is good news. Now, here are some very interesting data in the answer to the question about that one test. If you had only one test that you want to do on your patient to know their metabolic status and whether they're moving into the metabolic syndrome, it would be plasma triglycerides. These are old data, but they are nonetheless excellent data that show that the correlation between insulin response to oral glucose versus the plasma triglycerides. So as the value for the insulin goes up, indicating resistance to insulin, so does the plasma triglycerides, indicating that a measure of the plasma triglycerides is a marker for insulin resistance. So that's the one test. If you could only do one test, that would be the test to do. Again, as with weight gain associated with the bad antipsychotic drugs with respect to the metabolic syndrome, these are different among the drugs with respect to the fasting lipids. So the drugs that cause the weight gain, cause problems in terms of the metabolic syndrome, are the ones that elevate the plasma cholesterol, LDLs, triglycerides. So risperidone, LDL goes up, quetiapine, total cholesterol goes up, and olanzapine as well, but not with ziprasidone. Ziprasidone, for all these variables, is being reduced. It's probably not, it's not a statin, it's not reducing the cholesterol by acting on liver enzymes. These patients were switched from an antipsychotic that causes the metabolic syndrome, causes weight gain, to ziprasidone, and as a result, you're just going back to the level of these various lipids that they were at before they were put on a drug like risperidone, quetiapine, or olanzapine. Again, it's reversible, as with the weight gain, as with the triglycerides here, and the cholesterol as well. So here, again, similar data from the study on the switch. Again, the switch is to ziprasidone, and the switch is from conventional to ziprasidone, from risperidone to ziprasidone, shown here, or from olanzapine to ziprasidone. Now, here are the data for the conventional switch from conventional to ziprasidone. Not much change, as I showed you earlier with respect to weight gain. The conventional antipsychotic drugs, the older generation antipsychotic drugs, are not as much of a problem with respect to weight gain. So switching from them to ziprasidone doesn't change weight much, nor does it change the triglycerides. On the other hand, switching from risperidone or switching from olanzapine does, in fact, cause a very nice reduction in the plasma triglycerides. And again, this is correlated, this reduction in plasma triglycerides would be correlated with an increased sensitivity to insulin. So you're reversing the metabolic syndrome. The same with aripiprazole. Again, aripiprazole is not an offender with respect to weight gain, and hence the metabolic syndrome. And as with ziprasidone, again, you have improvement in lipids, particularly triglycerides. And again, what this is doing is reversing the problem that the patients had when they were on the drugs that cause increase in the metabolic syndrome. Now, here are data from the CADI trial. This is not in your handout, this particular slide. You have a table of those data, but not this graphical presentation. And for all the drugs in the study, the clear winner with respect to all these variables, weight change, cholesterol levels, hemoglobin alpha-1c, A1c, and triglycerides, was ziprasidone, which we call Geodon in the United States, and I think in Europe it's called Zeldox. It's also, in Greece it's Geodon. We almost had it, that trade name in the United States, but for some reason the FDA didn't like it. Okay, what is the metabolic syndrome, and what are the risk factors? And I think most of you got, or pretty close, got this correct. We need 3 or more of these risk factors to make the diagnosis of the metabolic syndrome. So what are these? Number 1 is, of these, you could have any 3 of these, makes the diagnosis. Up at the top is the waist circumference. Now this is easy, just to tape measure around the waist, just above the iliac crest. And in centimeters, if it's greater than 40 in men, that's inches, 102 centimeters in men, or 88 centimeters in women, that's 1 bag. Blood pressure, greater than or equal to 130 millimeters of mercury. Systolic, greater than 85, or equal to 85 millimeters diastolic. Triglycerides, greater than or equal to 150, and HDL. We think about total cholesterol, but it's more important to think about HDL and it's being low. You want HDL as high as possible, but if you have it low, less than 40 in men, less than 50 in women. That is one of the criteria for the metabolic syndrome. And finally, fasting glucose, greater than or equal to 100 milligrams per deciliter. So any three of these gives you the metabolic syndrome diagnosis in your patients. And these are relatively easy data to obtain. In general, in the United States, we have a terrible problem with respect to obesity in the adult population. I learned last night at dinner that another terrible problem that we have in the United States is the percentage of children who are obese. And apparently you have the same problem here in Greece. But in the severely mentally ill, we have those patients in particular are obese to begin with, regardless of the antipsychotic use. Schizophrenics have a higher incidence of diabetes than the general population. What I find also, and this relates to obesity, 1 to 2 times, 1.5 to 2 times greater than the general population. What I find very interesting is that 30% of schizophrenics have a family history of diabetes. And that compares to only about 5% of the general population, at least in the United States, who have a family history of diabetes. So they're already biased in the wrong direction here before we even give them an antipsychotic drug that makes things worse. So for these severely mentally ill patients, we have to consider that for schizophrenics, 42% obese to begin with, 75% smoke. Interesting phenomenon about schizophrenics, they smoke. In the United States, it's a little different from in Europe because the general adult population smokes less than 75%. But in schizophrenics, 75, 80% are smokers. Why are they smoking? Well, that's an interesting story in theory about they're treating their cognitive deficits with the nicotine, or they're treating anxiety using nicotine as anti-anxiety medication. Whatever the case is, another risk factor for cardiovascular disease in these patients, high prevalence of alcohol abuse, inadequate medical care. So this severely mentally ill population is really at risk for cardiovascular disease. Some more very interesting data in terms of myocardial infarction and what happens in terms of your risk if you have diabetes or don't. So let's look. We have about a 3.5% incidence over a 7-year period of having a myocardial infarction. If you've had one, your risk of having another goes up to about 20%. So having one increases your risk several-fold. But look here, if you have diabetes, your risk of having your first MI, your first myocardial infarction, is 20% over a 7-year period. And that puts you equal to a subject, a group of patients who have had one. So if you have diabetes, your risk of having a heart attack is equal to those who didn't have diabetes but already had a heart attack, myocardial infarction beforehand. So you are at higher risk, much higher risk, never having had an MI, and then with diabetes, 45% over a 7-year period. The folks in the United States have become very concerned about this metabolic syndrome with respect to treatment long-term with antipsychotic drugs, and the American Diabetes Association has come out with some guidelines for the monitoring of our patients who are on these drugs long-term. And these are the guidelines for monitoring. At baseline, there are certain things that we want to know about: personal and family history of diabetes and other metabolic problems. We want to obtain weight and body mass index, BMI. BMI is a very easy number to come up with. It is the weight in kilograms divided by the height of the patient in meters squared. And the perfect BMI is about 23, 25. When you take the weight in kilograms divided by the height in meters squared. And the American Diabetes Association is recommending that you measure this once you get the weight. The height doesn't change much over several weeks when you start therapy, and then every 3-4 months after that. I mentioned earlier about waist circumference as being a risk factor for the metabolic syndrome. You can do that at baseline and annually. Blood pressure, fasting glucose, fasting lipid profile. After 12 weeks, they recommend that every 5 years. I would move this over here to every annually. So let's look now at some other drugs, some anticonvulsant drugs, in terms of monotherapy for treatment of bipolar depression. There are good data for valproates in treating bipolar mania, placebo-controlled trial out to 8 weeks, separating from placebo at 8 weeks. Lamotrigine, also some very good data for treating bipolar depression. And what's interesting about these data is the fact that lamotrigine is working at such a low dose, 50 milligrams per day, is as effective here versus placebo as is 200 milligrams per day. There are also data for other anticonvulsants. Here we're showing the data for carbamazepine extended release in terms of mania and mixed episodes. And again, clear separation from placebo for a relatively large number of subjects. And this is early onset as well, within a week. So what about antidepressants treatment? I know there are some psychiatrists, at least that I've interacted with in the United States, who would never put a bipolar patient on an antidepressant. I don't think that way. But clearly, we know the data I presented yesterday, most bipolar patients, when they're not normal, when they're not euphonic, most of the time they're spending in the depressed phase of their illness, more so than the manic phase, so you need to treat the depression. Antidepressants are effective. Lots of meta-analysis showed that antidepressants are better than placebo for response and remission in patients with bipolar depression. But with respect to the use, the reason that some psychiatrists do not want to use antidepressants, bona fide antidepressants, is because the possible induction of mania. But you can approach that with the guidelines in terms of combinations of a mood stabilizer first, and then the antidepressant. Adding the older antidepressants, some think that the older drugs are more likely to tip patients off into a manic episode, tricyclics, monoamine oxidase inhibitors. So we want to use caution when combining them, and in particular if you use more than one antidepressant. We want to be cautious about using antidepressants in rapid cycling patients and in bipolar I patients. We don't want to increase the dosage of the antidepressant too rapidly in these bipolar patients. So there are a lot of good data to support the combination. Lithium with an atypical antipsychotic, especially olanzapine, risperidone, quetiapine, is the lithium atypical combination. Two different mechanisms of action. Similarly, Depakote with any atypical antipsychotic. That's the atypical Depakote combination. Evidence strong to support that combination. The olanzapine fluoxetine combination, which we call Symbyax in the United States. So here are some of the data to support that. The use of the combination therapy versus monotherapy, in this case, valproate versus lithium monotherapy. We have by itself monotherapy with valproate or lithium, and then when we add to that olanzapine, significantly improves the response in this case significantly with the combination of valproate and olanzapine. All the trend is towards better improvement in the combination with lithium and olanzapine. Well, in summary, multiple therapy is generally the rule rather than the exception in bipolar disorder. Combination of atypical antipsychotics with lithium or atypical antipsychotics with valproics is probably the best evidence-based treatment that we have to date. Any agents with positive evidence in bipolar disorders such as lithium, divalproics, atypicals, and the anticonvulsants can be rationally combined if they have different mechanisms of action. And although controversial, antidepressants remain an option for treatment in bipolar depression. Okay, let's now see how much you have learned. Which of the following has been demonstrated to reduce risk of suicide? Is it A, lithium, B, olanzapine, C, lamotrigine, D, A and B, or E, A, B, and C? Mark your keypad, please.
Give me a ticket for an aeroplane. Ain't got time.
Very good. Okay. Very good. Okay. And the women are ahead. Okay, next question. Which of the following has the best evidence of efficacy as a monotherapy in bipolar depression? Is it A, aripiprazole, B, olanzapine, C, quetiapine, D, risperidone, or E, ziprasidone? The best evidence. Mark your feedback. It's quetiapine. It's quetiapine. How many risk factors must be present in order to diagnose metabolic syndrome? Is it A, 1 plus, B, 2 plus, C, 3 plus, or D, 4 plus? You mark your keywords. Okay, very good. Amazing. Amazing. Okay, as a psychiatrist, you have just one blood test that you can order to know if your patients are at risk of developing metabolic syndrome. Which would it be? Would it be 1, fasting glucose, 2, hemoglobin A1C, 3, total cholesterol, 4, LDL cholesterol, 5, HDL cholesterol, or 6, fasting triglycerides, or 7, other? Mark your key. Is, of course, the fasting triglycerides. And very good. Very good. And very good. All right. And a virtual tie. No. Thank you.
Good morning. That was a great lecture, learning about triglycerides. This morning, now we're going to talk about some case for difficult problems. Some of these drugs you may not have heard of. Some of these drugs may be on the market in your country, some not. Some are used for other things. For even in the United States, the drugs we're going to be talking about are used for other things. Some neurology people here, one's for ALS, amyotrophic lateral sclerosis called riluzole, and other ones for Parkinson's disease. So these are difficult cases. And so this lecture is really meant for people who are clinicians, who are taking care of the world's worst cases. This is more about clinical than science, okay? And then I'm going to actually talk about 3 cases of my own practice after the break. So first, let's talk about tips. You know what a tip is? It's a helpful piece of information for managing difficult cases. Much of this is open label, case report, not double blind, because it's on the cutting edge. And so some of it may be too early to be true. Some of it may be disproven eventually. But if you take care of difficult cases, it might be something to help you. So the key points here would be to identify novel treatment options for patients who don't get better from everything else. Everybody in this room reads the literature. Everybody in this room knows all the large multi-center trials. This is not necessarily news to you. So what we wanted to do is to try to give you something that you might not know. We're going to examine treatment strategies for patients who fail to tolerate several agents. I'm going to give you some data now, and then after the break we're actually going to apply it, because your keypads will turn into a prescription pad after the break. We'll have real cases. This is just data from the literature. Then a little bit at the end we're going to talk about children and pregnant women, because those are special populations nobody seems to talk about, but they're very different in the way you treat them in practice. So I have a couple of tips for that. You may have seen this before. What's interesting is that the drug companies study the green, but all my problems are up here in the top yellow. Do you know that the bipolar spectrum is basically only bipolar 1 disorder, and only people who are manic in the bipolar 1 disorder? Almost all my patients have vague diagnoses. They maybe never were manic, but they're not clearly unipolar depressed either. And so part of the problem is, what do you do when there's no evidence? I still have to treat patients for whom there's no evidence. And this is what we're going to be talking about. First question. Which of the following statements is true? Number 1, clozapine is as well studied as the other atypical antipsychotics in bipolar disorder. 2, Due to its side effect profile, clozapine should be reserved for treatment-resistant bipolar patients. Number 3, clozapine is documented to reduce risk of suicide. Number 4 is 1 and 2. Number 5 is 2 and 3. Number 6 is 1, 2, and 3. Had to vote? Looks like some of you might know the right answer here. Next one. Clozapine is a rational, but it's an understudied option. There are very few studies and no double-blind ones. It doesn't mean you can't use it, it's just not studied. Open label shouldn't surprise you, and I have patients on clozapine that are bipolar, and probably you do as well. It's a rational option, in other words, it makes sense, because MOA means mechanism of action. Its mechanism of action is similar to all those drugs that Dr. Richardson showed you that are approved. Its advantages, it's the only antipsychotic proven to reduce suicide. It doesn't mean that the other antipsychotics don't reduce suicide, they just haven't been proven yet. The only 2 drugs proven to reduce suicide is clozapine in schizophrenia and lithium in bipolar. So if you have a very bad suicidal bipolar patient, you could consider clozapine. Of course, it has disadvantages, which are not a surprise to you. It's probably the worst drug for weight gain and diabetes, as well as, of course, in granulocytosis. And what Dr. Richardson told you is absolutely true. If you take a patient on clozapine, olanzapine, maybe quetiapine, and you take their blood fasting triglycerides, and they're high, it will be common. And if you take triglycerides on aripiprazole, now people here have amisulpride as well, in some countries. Amisulpride you can talk about because it's not as well studied. Or ziprasidone, triglycerides will not be elevated. Furthermore, if you take a clozapine patient with high triglycerides and switch him to any of those 3 drugs, amisulpride, aripiprazole, ziprasidone, the triglycerides go down, boom, like that in 4 days. If you don't believe me, try it. It's interesting. So this is the first part of having a cardiovascular problem. First thing, your triglycerides go up, and then your weight goes up. So it's very important to begin to monitor this to develop a risk-benefit ratio. I don't use clozapine a lot because it is a very risky drug, but to save people's lives, I use it. Here's the data that shows that clozapine in pooled state studies does reduce suicide, but you know this. How about adding lithium? Interesting. Lithium was generally studied in depression as an add-on to antidepressants. Today, we do it differently. Today, we usually have somebody on lithium who's bipolar, and then we add an antidepressant, because it's considered dangerous to give antidepressant monotherapy to patients with bipolar disorder. And so most of the studies were done in the wrong direction. In other words, you take studies of people on an antidepressant that are not doing well. And in the old days, some of these studies from the 1980s, this was before everybody had bipolar disorder. Now they all have bipolar disorder, but I think maybe they had bipolar disorder back then, we just didn't call it bipolar. But this is to add a placebo to a patient not responding to an antidepressant. And this is to add lithium to a patient not responding to an antidepressant. Everybody knows this. Lithium is a very good drug to add to people who are doing poorly. And guess what? Antidepressants can be added to lithium if lithium doesn't work completely. Either direction. Next question. Which of the following agents carries the highest risk of serious rash? A, lamotrigine, we call that Lamictal. B, carbamazepine, we call that Tegretol. C, levetiracetam, that's an anticonvulsant we call Keppra. D, zonisamide, is also called Zonegran. E is A plus D. I have some sexy new anticonvulsants for you to use. And most people don't know the answer to this question. Most people think it's A, but as I will show you, D is also bad because zonisamide is a sulfonamide. Sulfonamides are antibiotics that cause very bad incidence of rash. So the correct answer is A, but also D. So we'll show you. Next one. Go on. I'll prove it to you. It's some data. Okay. How about levetiracetam? Keppra. Do you know what this is? Do you have Keppra in some countries? I'm not sure it works. It's an anticonvulsant. There's some bad, poor design, open studies for bipolar disorder and for pain. Do you know how it works? Its mechanism of action is it blocks a protein in the wall of a synaptic vesicle. If you care, it blocks the SV2A protein. And by doing that, it prevents glutamate release. It's the only anticonvulsant that does that. It's not yet clear if it works for mood stabilizing. It is an anticonvulsant. It's a funny drug because you have to give it like in 500 milligrams to 3 grams. It's a very high dose. It's not renally, it's not metabolized. It's only renally excreted, so it has no drug interactions. So it's got a high dose. If you dose it like you do in epilepsy, some people think it works a little bit. It's in the literature. I'm not impressed in my practice. It's not harmful. It has very little side effects. I just don't think it works. But you can try it yourself. More studies are ongoing now. This is Stevens-Johnson syndrome, also called toxic epidermal necrolysis. This is a life-threatening rash. It's most famous for Lamictal, about 8 to 13 per 10,000. But it's very high also with sulfonamides. Zonegran, zonisamide, just like it sounds, zonisamide is a sulfonamide. So you need to know that there's risk of rash with that anticonvulsant. In fact, you see on the slide, the risk of rash with any anticonvulsant is more than 0. Even valproic acid and phenobarbital. Carbamazepine, they're all on this list, but they're low. Zonisamide is something we're trying in the United States. It isn't clear if it works yet, but we sometimes use it in treatment-resistant patients. It's between 100 and 600 milligrams. Does anybody know of Pearl, a special fact about this drug? It might cause weight loss, particularly in women. Perhaps better than Topamax. But you have to warn about rash just like you do with Lamictal. It's not common, it's just not 0. It also has some risk of kidney stones, just like Topamax, topiramate. But there is some evidence for weight loss, so that's what this is also used to add on. Riluzole. Has anybody ever heard of this drug before? It's actually an anticonvulsant, but it was never developed for that. It is used for amyotrophic lateral sclerosis. It is thought to work by preventing glutamate release. Do you know another drug that we use for bipolar that is an anticonvulsant that works by stopping glutamate release? lamictal. This has the same mechanism of action as lamictal. So if you have people who have the bad rash on lamictal, or who don't respond to lamictal, you might try riluzole. The problem is there's not very good studies. The best one is Zarate. He does a lot of interesting early studies, Italian psychopharmacologist. And he showed that in an open study that if he added it to riluzole to lithium in bipolar depression, it seemed to work. There's been a recent study, I do not have a slide, adding riluzole to bad OCD. Basically, there are some tips if you're going to use this drug. You need to know that it's still in process, but I have seen it work maybe twice in my practice for very bad cases. I prefer lamictal first. I don't use this unless lamictal fails. This is the Zarate study. Most got 150 milligrams or more. Divided dose twice daily. ALS dose is the same. Might be a little higher for depression. The biggest problem is it makes liver function abnormalities, and it's less well absorbed with food. About half of people have liver function elevations. You need to monitor it, and you might not stop the drug. You might go right ahead and just realize that if you have to give this drug, you may have to have some slight liver elevations, or don't use the drug. That's its biggest problem. You're the clinician, you decide the risk-benefit. Pramipexole, do you know this drug? Pramipexole is a D2, D3 partial agonist for Parkinson's disease. Psychiatrists should be using it. This afternoon we'll talk a little bit about restless leg syndrome. Psychiatrists should be treating sleep disorders. One of the problems that people have excessive daytime sleepiness is because they have restless legs at night. This is one of the treatments not just for Parkinson's disease, but for that. But you could also use it for bipolar II depression. Here's our friend Zarate again. Open study. I know this is a double-blind study. Placebo, 11 patients, pramipexole, add-on, better than placebo. But these are some of the world's worst patients. These are non-responders to lots of other things. And some tips for using pramipexole is that you would give a dose estimated to be how you use it in Parkinson's disease or in restless leg syndrome. 0.375 3 times a day. This is difficult because people do not like taking medicines 3 times a day. You might be able to do it twice a day, but certainly not once a day. The total dose is at least divided into 2 or 3. Slow titration because you can get vomiting, nausea, hypotension, and I don't know what the right dose is. Maybe 4 or 5 milligrams. What works and what's tolerated. Just dial the dose up. Preliminary data are in bipolar II depression, but be careful because this is a dopamine agonist. It might activate some people. So generally I don't give this unless the patient is already on another mood stabilizer. A sister drug with even less data is another Parkinson's drug, also used for restless leg syndrome, also a D2, D3 partial agonist called ropinirole. Ropinirole has the same mechanism as pramipexole. No controlled studies, but Cassano, who's another good Italian psychopharmacologist, has some open-label experience. Reduced depressive symptoms in open trials of treatment-resistant depression, augmenting antidepressants. Its tolerability is the same as pramipexole, some dizziness, some faintness, some hypotension, so go slow on the dose. and people tolerate it if you work it up slowly. And it would be the same as in Parkinson's disease, or a little bit on the low end, 0.75 to 1.5 milligrams a day. This is all in your handout. Memantine, do you have this in your countries? This is a famous German drug that came to the United States. We call it Namenda. There's an unfortunate recent study in the American Journal of Psychiatry that says it doesn't work. So maybe I should pull this slide. But it's like everything else in medicine, there's a new scorecard. The study was done by Zarate again with Dennis Charney, and certainly it probably works for Alzheimer's disease, but what I meant was the American Journal of Psychiatry paper said it did not work for treatment-resistant depression. But there are some people who think it does work. It's an interesting drug because it may be sort of like an artificial magnesium, a kind of blocker that can be reversed with neurotransmission of the neurotransmitter glutamate at NMDA receptors. It is used at 5 to 10 milligrams a day. It's interesting at 20 milligrams. It's a drug that's got a 50-hour half-life. I should ask the Germans why they use it twice a day. A drug with a 50-hour half-life, but as the Americans did the same thing for their studies, it really makes no sense, but that's how it's used with the rollout food. But what I like better is its sister. Did you know that memantine's sister is amantadine? Amantadine has a little bit of the NMDA properties of memantine, but it also releases dopamine better. And if you remember, this also has been used for EPS in the old days when we had conventional antipsychotics. And this is more interesting to me. It's like pramipexole plus memantine. You see? You have two mechanisms. And I like the dopamine mechanism of this drug. Its dosing is usually 100 milligrams a day, maybe 100 milligrams twice a day. If you give 100 milligrams 3 times a day, you can get some visual hallucinations. Have you ever seen that? Do you remember the book called Gulliver's Travel? And he went to this island, and he had these little people called Lilliput. With this drug, you can cause the Lilliputian syndrome, in which you look at somebody and it looks you look really tiny. It's a type of a visual illusion or a visual hallucination. If you see that, the dose is too high. You can see that in Parkinson's disease. About 100 milligrams or 100 milligrams twice a day, you can add this on to treatment-resistant bipolar depression. Because it works and is activating, it might cause mania if no mood stabilizer is present, and it might cause some suicide attempts, so be careful with the drug. Any drug that works can do this. Does anybody know what sodium oxybate is? It's also called gamma hydroxybutyrate. In the United States, it's just been approved as an orphan drug for cataplexy. And now the FDA has made it more than cataplexy, now for narcolepsy and daytime sleepiness. How does this drug work? It is the most powerful inducer of slow-wave sleep we know in humans. We have some sleep experts in the audience, they know this. Isn't it interesting? Because this was a very nasty story, because it's a drug of abuse. Gamma hydroxybutyrate was abused by Olympic weightlifters. Now, why do they do that? Because when you have slow-wave sleep, what is the hormone that goes up in a huge surge? Growth hormone. So what the weightlifters figured out is if you took it in a hypnotic dose several times during the day, their growth hormone would go up and they could cheat. Very smart weightlifters. I don't know how I would have figured that one out. Anyway, because of this, and also it's been called the date rape drug. The most famous date rape drug is rohypnol, but this was used a little bit also. So this was banned, and it's also only got a 1 hour half-life. So it's a very difficult drug to take, and it only comes in a liquid, and it's huge doses. But what we found is that it's a scheduled drug. There's only one pharmacy in the United States that must distribute all this drug because it's highly controlled. But it's a liquid, a half a gram per ml. Its dose is very interesting. People are told to set their alarm clock. And what they do is they take the first dose, which is generally 2¼ grams in water, and it works so fast that you have to sit at the bed, have your alarm clock set, go like this, lay down. And it works boom like that, and you get a lot of slow wave sleep. The problem is you wake up, and you're told for cataplexy to take another dose. Even if you don't wake up, you set your alarm clock, so 2 hours later you're supposed to wake up. In the United States, we're beginning to use it off-label for some of the worst cases of pain, because slow wave sleep is very good for certain people with pain. This drug is being investigated in fibromyalgia, and so you may see it come forward. It may be useful in some bipolar patients and some of the worst anxiety patients, but obviously this is a dangerous drug. It's a difficult drug. It's an expensive drug. You may not even have it in some of your countries now, and maybe you will never have it, or it will come. But I wanted you to know what's going on in our field, so you heard about it here. Some people believe it actually stimulates GABA B receptors, and this is how it actually makes you sleep. If I would ask you, what other drugs do you already have, if not sodium oxybate, what are the best drugs to improve slow wave sleep that you already have? There's not very many of them. Gabapentin, Neurontin, pregabalin, Lyrica, same thing. And the other one is Gabatril. Some of you may not have that. Tiagamine. This is a selective GABA reuptake inhibitor. And because it makes GABA go up rather than a benzodiazepine, it stimulates GABA B receptors and may have something in common with how this drug works. So if you have patients who need slow wave sleep, you have a limited number of options already. These are something unique because I think that basically what I tell our residents is that sleep is like a psychiatric vital sign. Let's go to the next question. Bipolar patients with prominent sleep disturbances may not respond as well to traditional sleep aids as other patient populations. Do you think that's true or false? Most of us would say this is not necessarily a right or wrong answer, but most of us are true. You know, like Professor Salgado is here, some various other sleep experts. Most of the studies to register sleep drugs are done in patients with easy sleep problems, like primary insomnia. But most of the treatment in practice is in tough patients that have a psychiatric disorder or a medical disorder and a form of secondary insomnia. Do you think that the dose of a sleeping pill for a patient with bipolar disorder or pain is higher than it is for a patient with primary insomnia? Yes? How many is lower? Nobody. Basically, sleep is a very important thing for psychiatric patients, whether you have pain or you have bipolar disorder. And I told you yesterday, the Favas study, you remember that? Where if you added a hypnotic to someone who is not in remission from depression, not only does his sleep get better, but so does his depression. There is something curative about sleeping, no matter what's wrong with you. And it's important important to try to empirically remove insomnia wherever you see it. And so my residents give me a bad joke. They call it Stahl's vital signs. I say pain and sleep are vital signs for a psychiatrist. In other words, instead of taking the pulse and the temperature, now Professor Richardson has told you you've got to take triglycerides. There's certain things we have to do as psychiatrists. But we have to become better sleep doctors as psychiatrists. This afternoon we'll be talking about that. Because if we can improve sleep, this is more likely to help a lot of things. Now, you have atypical antipsychotics, some of whom, particularly Seroquel, for example, are H1 antagonists, but also the 5-HT2A antagonist properties of drugs contributes to possibly improving slow wave sleep. Do you know a drug you already use that's better known as an antidepressant that's a 5-HT2A antagonist? Trazodone. Another one, someone asked me yesterday, mirtazapine. Mirtazapine has H1 and 5-HT2. There's lots of ways to get a patient to sleep. I don't care how you do it, but please help them sleep because lots of things get better when the sleep improves. So some of the strategies for treatment-resistant depression that you may not have heard of, does everybody have vagal nerve stimulation in any country? Yeah? It's very interesting, isn't it? I won't have time to talk about transcranial or ECT, but just for the fun of it, the vagus nerve is an interesting nerve because I used to think it was something that made you do digestion and start your heart and all this stuff, and it wasn't a psychiatrist's nerve. But it is a psychiatrist's nerve because it also goes up as well as down. It goes in, information goes into the brain through the vagus nerve, not just out. And it regulates not just sensory input, but relays one synapse away from the famous neurotransmitter sites. So the nerve comes in from your neck up into the nucleus tractus solitarius, and one synapse away is in the raphe and the locus coeruleus. So it looks like it may influence neurotransmitter release anatomically. The story of this, of course, is that vagus nerve stimulation was first used by neurologists for treatment-resistant epilepsy. I don't know if you've got experience with this, but I once saw a patient in a clinic with a colleague of mine having a seizure that had one of these implanted. And he went up to this patient and turned it up with a magnet. She stopped her seizure just like that. It was very impressive to me. Anecdotally, people found that epilepsy patients getting this treatment who were depressed as well as epileptic had their depression get better. So this led to studies in patients with depression but no epilepsy. And also from this theoretical point of view, that if we think most antidepressants boost norepinephrine and serotonin, this nerve is one synapse away from the headquarters for those. So the device is implanted like a pacemaker under your skin, and then a neurosurgeon or an ear, nose, and throat surgeon does a procedure under general anesthesia where they put the probe into your left vagus nerve because the right one is too much involved with bradycardia. And the stimulus frequency can be set by an external computer at 5 hertz frequencies. You go 5, 10, 15, 20, up to 30. And the usual problem is just hoarseness. Dr. Richardson was telling me he has a patient that he's implanted, and she has very bad stomach aches. Sometimes you see that in 10% of patients. This was just approved by the FDA. I have 4 patients that are with this, and it's a little bit too early for me to understand exactly how enthusiastic I am about it. It doesn't seem to work quickly. it seems to work over months. So some of the data that led to the approval are here. You have response on the left, 3, and remission on the right. And what it shows is that there's a very slow improvement over about a year. The problem with this study is that the patients were also receiving antidepressants, and the antidepressants were often changing over time. The criteria for approval of a device, at least in the US FDA, is much less severe than the criteria for approval of a drug. So they did not have to have a good parallel group of controls, and they did not have to have 2 studies. But what we think we see is that this phenomenon on the far right, where some of the worst patients are going into remission at 3 months, there does seem to be a general increase to about a third of patients, but some of them take up to a year to respond. This is even slower than an antidepressant. TMS, lots of this is going on. In fact, much of the good work is done in Germany and Switzerland. Does it work? I don't know. Does it work when you stop it? I don't know. Interesting possibility. A magnetic stimulation or a magnetic seizure. Might replace ECT, but right now ECT probably works better. What's in the pipeline? I could give you a whole talk on this, so I won't waste your time. Metabolite of risperidone is in testing. I don't think it has any particular advantages, except it will extend the patent life and continue to be an expensive drug. Risperidone will be off patent soon. It's an excellent drug, so it'd be hard to know whether this one will be able to replace it. There's another one that's more interesting, bifeprinox. Do you know this drug? This is a D2 partial agonist. It's more partial than aripiprazole, the other partial agonist. This drug is a Solvay drug, which is being developed in the United States in partnership with Wyeth, and over here in most countries by Lundbeck. And it's going to be an interesting drug. It's hard to use because it can make you vomit and have hypotension. So you have to dose it slower. Have anybody ever seen some vomiting with Abilify? Yeah, occasionally. But this is even more partial, so it does even more. So this will be a drug that will be hard to use for acute mania because obviously you want to hit them hard and the dose is going to have to go up slow. So it's more an outpatient drug, but it does not have 5-HT2 properties. It has 5-HT1A. I don't know what this means, it's just interesting. Iloperidone is probably dead. Acetopine is very interesting. Acetopine is an organon drug that's now in partnership with Pfizer, and this has mirtazapine embedded in an antipsychotic. So it should be a very good antidepressant. It has powerful alpha-2 antagonist properties. So someone was asking about mirtazapine yesterday, sitting over here. This is mirtazapine in an antipsychotic. So I think this could be a great treatment-resistant depression drug. This could be a great bipolar depression drug. Keep your eyes on it. Next question. This is difficult, but I think it's important to read. Which is true? A, lithium is the best evidence treatment for postpartum prophylaxis of mania, this means, and is the most preferred treatment during breastfeeding. Is that true, A? How about B? Lithium is the best evidence treatment for postpartum prophylaxis, but may be the worst for breastfeeding. Or C, lithium is just as good as other mood stabilizers for prophylaxis, but is most preferred during breastfeeding. Or D, lithium is as good as the other ones for prophylaxis, but is the least preferred. What is your answer? Go ahead and vote. Let's go backwards. Lithium has the best evidence. It may not be better, but it's been studied better. Okay? So if you want to say what is proven to work the best in a pregnant woman who delivers, it's Lee Cohen's work from Harvard. Do you know how many women will relapse into mania if they're unmedicated when they deliver? 50% in 4 weeks. And the best studied treatment is lithium right after delivery. That's the good news. The bad news is the worst thing you can give a baby. Because lithium is secreted into breast milk because it's dissolved in the same concentration as therapeutic dose. So the baby is getting a full dose of lithium. So it's the best evidence, but the worst treatment. So their answer is B. So if a woman needs the lithium, she can't breastfeed. If she must breastfeed, she has to use something else. Okay, next one. Back to my slides. So here we go. The FDA and EMEA have these various criteria for risk. Category B means there are animal studies that don't show adverse effects in animals during babies being developed, usually in rabbits and in rats. C is not a bad rating. D is a bad rating. So if you are treating pregnant women, you can't use D's. Okay? Now, you would like to say, is C good? There's lots of, if we have a neurologist professor here, we have lots of people who know about anticonvulsants from neurology. Lamotrigine is a good drug to give during pregnancy. The neurologists like this drug. Valproic acid is a poison. Terrible. But lamotrigine, the problem with that is the levels go down during pregnancy because of the metabolic changes, so you have to raise the dose. So if you're a psychiatrist and you're treating women that could become pregnant or are pregnant, you want to use atypicals or lamictal, not valproate, not carbamazepine, probably not even lithium. But here's the problem. If you have a 14-year-old girl in your practice who is not sexually active, what drug do you put her on? Because in the United States, anyway, you can become sexually active in 20 minutes. And this is the problem, is it's hard to speak to young girls about sex if they're virgins and not active yet. And yet if they have a bipolar disorder, they could be impulsive and act out and get pregnant on the drug you're giving them. So what do? It's a difficult situation. And so we generally are more worried about these drugs, about these drugs here. So if I have girls that might get pregnant and are impulsive and not taking birth control or various sorts of risks for behavior, I use these drugs, lamictal and atypicals. And because I don't want them to get fat and diabetic, I use ziprasidone and abilify. And because ziprasidone and abilify are impossible to dose, you better come back after the break because we're going to talk about how to use them. Because if you use Zyprexa, it'll work really good for these girls, but then they'll get diabetic and polycystic ovaries with the, it's a tough situation, isn't it? So part of this is understanding the special needs. Now, here's the problem. Once you have a baby, you deliver it, you have to treat that mother. It's malpractice not to treat a bipolar mother after delivery. So what do you give them? Well, you have to, first of all, coordinate this with obstetricians and pediatricians. You weigh the risks and the benefits both during pregnancy and make a plan for after delivery. If the mother is not going to breastfeed, in some ways it doesn't matter. If the mother wants to breastfeed, you might need to think about what you're going to use during pregnancy. The one thing that you know from lithium that Dr. Richardson told you is it prevents suicide. And I just told you that it was really great to prevent recurrence after delivery. But if you stop it too quickly, you create suicide. Dr. Baldesserini's studies show that rapid stopping of lithium actually makes people more likely to commit suicide. So very carefully stop anything that you're going to stop. Don't panic just because the woman's pregnant. You got two patients, the baby that's not born and the mother. And so it's difficult. If the patient during pregnancy is taking lithium, valproate, or carbamazepine, these things are bad for the baby. Stop them slowly and consider switching them to an atypical. You might not want to use Risperdal. Is there any proof of this? No. But if you ask me, does it make sense for me to give a drug that raises prolactin to a baby who's not born yet? I don't like that idea, do you? I just say I've got other options. I also don't want to make the mother fat. So, you know, you have 5 drugs, 6 if you cause clozapine, 7 if you add amisulpride. You make up the idea which one you want to use. But I don't particularly like giving pregnant women Risperdal. Postpartum, it depends on whether they're going to breastfeed or not. But there's a 50% relapse within a month if you don't treat. So you have to start women generally just before they deliver. Lithium has the best evidence, but if you're going to do that, you should tell the mother not to breastfeed. Okay? If you're, actually, the funny thing is Depakote, divalproex, is one of the worst drugs during pregnancy and is a good drug after pregnancy. Why? Because very little of it gets the breast milk. And it's good for the mother and the baby doesn't, I mean, you never say 0. If a mother's on a medicine, there's some trace that's going to go in the breast milk. Same thing with an atypical antipsychotic. But if a mother's on Depakote or an atypical after she delivers, she probably can breastfeed. Now, what about children? In the United States, we've gotten to the point that all bipolar children are ADHD and all ADHD children are bipolar, and oh my gosh, it's just crazy. We can't tell the difference anymore. And it's very interesting. It looks like there are more children with bipolar comorbidity, and it goes down when you're an adult. In fact, if you look at the next things, how do you tell the difference between ADHD versus bipolar? You can't in a child with energy or distractibility. Geller says maybe grandiosity, elation, and hypersexuality. This is probably the best one because I can't tell what's a grandiose child and what's a normal child. Can you? I think the nature of childhood is to be a little grandiose. So, I mean, if it's way excessive. But what's interesting is this as well, particularly this line right here. All children have ADHD if they're bipolar. Half of adolescents, more or less, have ADHD, but the adults don't. Now, you remember yesterday's lecture about overactivity? If you're overactive and you're 10 years old, you're crawling on the table as a little boy, what do they call this? They call this a hyperactive boy, right? But if I'm doing it at 54 years old, you're going to call me manic. Same behavior. So maybe what happens is overactivity occurs across the age range, but the diagnosis changes. And that's called stupid psychiatrists. I don't know what it is, it doesn't matter, but you need to treat the symptom. That's what we're talking about. That's the whole thing. It's treating symptoms, correct? And so this whole idea of what's bipolar and what's ADHD, there's no answer. But I'll tell you one thing that's interesting, is if you have bipolar and ADHD, mood trumps cognition. If you don't stabilize mood first, you got no chance on cognition. So you have to, it's actually very easy because you don't have any choice. If you've got mood problems and cognition problems, treat the mood first and stabilize it. Once that's stable, you have a chance to then go after the cognition. You will have to treat both, but know which order to do it in, because if you try to treat cognition in someone who's got unstable mood, you will never succeed. In summary, many patients present with subtypes of bipolar for which treatments have not been studied. For patients who fail to respond to bipolar treatments that are the traditional ones, you can try clozapine. Augmentation with all those crazy drugs I showed you, novel agents. Some might work, some might not. You go find out. In fact, you should email me, tell me how many of these were stupid ideas and how many of these were good ideas. That's how I learned. VMS, maybe. Improve sleep wherever you possibly can. Psychiatrists must become better sleep doctors. Psychiatrists must become better diabetologists. Psychiatrists have got to work on the edges of their expertise and constantly increase the frontiers of their knowledge. Children who appear to have bipolar illness may respond better to atypicals, actually. Children don't like getting blood tests, they don't like taking drugs twice a day. This is one of the reasons why atypical antipsychotics, particularly the ones that don't cause diabetes, are the real preferred treatments in children. Again, if you want to be a modern psychopharmacologist and not make people have bipolarity and treat women that can get pregnant with children, you got to know how to use Abilify and Geodon. If you want to do that, come on back after the test. We're going to have lunch. But let's do the post-test, and then we'll have a break. Which of the following statements is true? Clozapine is as well studied as the other atypicals in bipolar? Or 2, due to its side effect, clozapine is second line? Or 3, clozapine reduces suicide? 1 and 2, 2 and 3, or 1, 2, and 3. And the answer is not 1, but maybe it's 2 and 3. Therefore, 5. Correct? Good! The girls going to beat the guys again? Oh my gosh! There's only about 30% of the people in the audience are women, but they're more powerful than the men! Which of the following agents carries the highest risk of serious rash? Lamictal, carbamazepine, Keprov, Zonogram, or A and D? Most of you knew A, but maybe you learned it's also D. A plus D equals E. Yes. Good learning. Oh, look at that! Come on, boys, wake up! Bipolar patients with prominent sleep disturbances might not respond as well to traditional sleep aids as other patients. True or false? And that's probably true. You have to raise the dose or use more aggressive treatments. True? Yeah. Most of you knew it? Oh my gosh, the girls really got it this time, all put together. And which of these is true? Lithium A is the best treatment and the best for breastfeeding. B, lithium is the best evidence treatment and the worst for breastfeeding. C, lithium is equal treatment and best for breastfeeding. Or D, lithium is an equal treatment and worst for breastfeeding. Best answer. D.
emotional efficacy line, no SSRI other than fluoxetine will work for her depression. In light of this mood, should I start my patient on fluoxetine instead to treat the depression? Alternatively, should I advise her to wait to move until after her 18th birthday, at which point sertraline should resume its effectiveness in the United Kingdom? At least she's not moving to America, where any antidepressant would make her kill herself. Please, offer whatever advice you can. Sincerely, Martha J. Talbot, MD.
Well, that's making a little bit of fun of the FDA's regulatory agency. So, we're going to have a case-based workshop now. You want to re-register the keypads? Actually, we don't really need to do that right until after lunch because this is not a competition. So, we're going to actually go through 3 cases of my practice, and I'm going to ask you to work with me on real cases as they develop. So, let's start with the first one. This is Mr. F.H. He's a 50-year-old man, attorney, non-smoker, doesn't use drugs or alcohol, high triglycerides, family history of depression, sister and father, and although I'm seeing him at age 54, when he looks backwards, he realizes he has his first depression as a law student at age 24. Probably major depression. It wasn't recognized, it wasn't treated, and it spontaneously remitted. His second episode was at age 36 in 1986, and this then is about 20 years ago. And he had a very severe case. He was unresponsive to numerous agents. 1986 was before Prozac, remember? So he took tricyclics, probably some MAO inhibitors, but he doesn't remember. They made him jittery. They made him overactive. So he went to ECT. He had a short but not good response to ECT. And then in the United States, his physician in New York City was reading the literature and realized that anafranil, clomipramine, was a powerful antidepressant. Now, if you remember, this drug only came to the United States in the 1990s for OCD, but he imported it from Europe, and it worked. One problem. He had pins and needles, paresthesia feeling in his feet. He hated this, but his depression was much better. So he took it for many years, but then got a third episode because he stopped it, because he got tired of the side effect and wouldn't take it again. So his doctor gave him, at this point, in 1990s, there were SSRIs in the world, and gave him fluvoxamine, and he did very well. Now here's the problem. He then relapsed on drug. So the first relapse was because he stopped his drug. The second relapse was on drug. And now he's in big trouble. Because the doctor who is treating him from New York is trying all sorts of medicines, and actually this doctor went to some of my courses over the years and finally sent him to me after 4 years of trying various medicines. So now I see him in 2005 with a very good doctor from the audience of one of these courses. He says, I don't know what to do now, let's have you see the patient. And what's he like? Now he has bad generalized anxiety. No panic, but when he gets up, he's just tense and awful. irritable, agitated. He snaps at his wife. He argues with his clients. He's a lawyer. And yet at the same time, he has withdrawal, lacking energy, motivation, no interest. His sleep is okay. He has a hard time concentrating. When he first relapsed in 2000, he stopped working. Now he's back at work on these treatments. They help a little. He's at 375 of venlafaxine, 400 of lamotrigine, modafinil 200, and alprazolam up to 2.5. So now he comes to me, and let's say he's come to you with this story. What do you do? Number one, first of all, what do you think his diagnosis is? A, recurrent major depression with anxiety and treatment resistance. B, soft bipolar spectrum depression with mixed state, but not full criteria mania, but full criteria depression and treatment resistance. Or C, I don't care. He clearly is not bipolar 1 or 2, but the question is whether or not the antidepressants that activated him gave him a bipolar 3. Remember the bipolar 3s? I think you're right. I think you're right. Let's see the next question. Do you believe that whatever his illness was at age 24, remember that was his first unrecognized symptom? And now he had one 20 years ago, and now he has a terrible one today. Really 3 major episodes, the last one untreatable. Whatever this illness is over the last 30 years, do you think it's progressed over time to a different illness? And then he's developed treatment resistance? So A, you agree the illness is progressive, or B, you disagree, you just haven't found the right treatments. He was always difficult to treat. What do you think about this illness? Because I think the answer, with no proof, is A. I don't know the right answer, but I have the sense that people that have more illnesses change over time and they become more difficult to treat. But this could just be wrong. It's not easy. All right, here's the question. Remember, he's on venlafaxine, lamotrigine, modafinil, and alprazolam. Now what are you going to do? Give him another antidepressant? A. Give him another mood stabilizer? B, which means lithium or another anticonvulsant. C. Give him an atypical antipsychotic. D. ECT. E. Vagal nerve stimulation. Whatever. What are you going to do to this man? Interesting to see what you say. Most people agree with you. They would give him an atypical antipsychotic. Okay, let's look. The rest of this exercise, we're going to use the same menu for your prescription pick. If you would give him an antidepressant, maybe you wouldn't, but if you would, which would you do? Remember, he's on venlafaxine. This same is going to be all, you'll see this again and again. 1 is one of the SSRIs. 2 is SNRI. 3, tricyclic. 4, MAO. 5, mirtazapine. 6, bupropion. 7, nifazodone or trazodone. 8, stimulant. We'll talk some more about modafinil after lunch, but also amphetamine or methylphenidate. 9, raise the dose of what he's taking, like he's on 375 of Effexor. You would raise it. Or 10, I would not give an antidepressant. what would you do? So mirtazapine is popular. That's California rocket fuel. Raise the dose. That's popular. Or do nothing and give him something else. That's popular. If you would give him a mood stabilizer, which one would you give him on this list? Remember, he's already on lamotrigine. Lithium, number 1. 2 divalproax. 3 lamotrigine. 4 carbamazepine. 5 oxcarbazepine. You know this drug, Trileptal? Topamax, topiramate, Keppra, we talked about that this morning, levetiracetam, zonisamide, that's also known as Zonegran. And then you have gabapentin or pregabalin, or tiagamine, this is also called gabatril. So what would you give him? You don't have to give him anything, but if you give him something, what would you give him? Remembering he's already on the way. The most popular here would be lithium. Okay, now finally, if you give him an atypical, which would you add? Clozapine, risperidone, olanzapine, quetiapine, prazodone, amisulpride, aripiprazole, a conventional, or a depot. Remember, Dr. Richardson showed you evidence that bipolar disorder's depressed phase is treated with atypicals, right? And you would give him? Interesting. Very interesting, because that's exactly what I did. Next. What happened in real life? He stayed on his venlafaxine. I could have increased the dose. I thought about that. I also thought about giving mirtazapine because I like mirtazapine. But he's already on Lamictal, and I thought he needed more mood stabilization. So he's still on this. He actually stopped his alprazolam. I don't know why. Because I saw him once in California and gave him some recommendations. And we started quetiapine 100 milligrams in the morning and 200 at night. And it didn't work. What would you do next? And the answer is, I tell my young residents, time is a drug. And 4 weeks is not enough, and 300 milligrams is perhaps not enough. So I did almost nothing. I just waited. Increased it slowly after 4 weeks of no response to 200 in the morning and 600 at night. So he was taking 300 a day, now he's taking 800 a day. Now he's got a lot of sedation on this, but it slowly gets better, and the patient has been well for 2 years. So, the moral of the story is, he looked to be a little bit progressive to me because he relapsed on drug. If people stop drug and relapse and then take drug and respond again, that's not so bad. But what happened is he was on a drug and stopped it and relapsed. Went on a drug and responded. Then relapsed on drug, and then you gave him other drugs and he didn't respond very well. This has the pattern of less and less responsiveness. This can happen. It doesn't necessarily mean he's bipolar, but it may mean that bipolar drugs could work no matter what his diagnosis is. I don't actually care what his diagnosis is. I only care how to treat him. So I say time is a drug. Sometimes the response is don't do anything. Let the drug have some more time. My residents say, I've got to do something. And I say, keep doing the same thing. Raise the dose a little bit. But I feel anxious. And I said, well, you can come to my office. I'll give you psychotherapy, but don't mess around with the patient. Quetiapine can be tricky to dose. 25 to 100 milligrams is sometimes all that's tolerated, and that can work, particularly for hypnosis as a sleeping pill. But the problem is, it doesn't always work. Then you have the other problem. You remember the data that Dr. Richardson showed you is that 300 to 600 milligrams were the doses for bipolar depression. Quetiapine has the best data for bipolar depression. It doesn't mean that there's 5 drugs. They probably all are just behind. It doesn't mean they're not as good. It's just they're just taking longer to do their studies. But quetiapine, do you ever give a depressed patient 600 milligrams of quetiapine? This is a huge dose. They are going to have a hard time tolerating it. But over time, many of them get used to it, and it can work. And I like quetiapine, particularly if there's daytime agitation and if there's nighttime insomnia. But I don't like it so much if there's hypersomnia and fatigue. Case 2. This was a tough one. 60-year-old doctor. Actually, he's a psychiatrist from San Francisco. Master of public health. Non-smoker, rarely drinks, divorced 3 times, no children. He's got Crohn's disease and takes azathioprine and Remicade intravenously. Here's his family history. His father has some sort of sleep disorder. He doesn't know any more details. His mother was depressed, but he doesn't know if it was bipolar or unipolar, but he does know she got ECT. His maternal uncle and maternal aunt were depressed, and his maternal grandmother was called bipolar, and she was hospitalized in the late 19th century. Now, one of the problems with family history of mental disorders is 100 years ago is a long time ago to make a diagnosis. And so we don't necessarily know what the names of these things are over time. But something seriously was wrong with her. He presents to the physician in San Francisco with sadness, anhedonia, guilty ruminations, passive thoughts of death, and a sleep disturbance, with middle insomnia and early morning awakening. He also gets anxious at the night time when he wakes up. But in the daytime, he's got decreased energy and problems concentrating. He's irritable, anxious, but no panic. So far looks like it's anxious depression? Maybe. Past history. If you ask him how he was as a child, he said he was very anxious. He had separation anxiety, difficulty going to school. And he, remember, had a mother and a grandmother that had mental illness. And he thinks that she was emotionally abusive to him. And he's had 3 marriages, so he has many turbulent interpersonal relationships. He probably had OCD, but this isn't clear because he's a physician and a psychiatrist. Most of us have to have a little bit. How much is too much? Maybe he had a little too much. No significant substance abuse. His first psychiatric treatment was as a medical student. This was before Prozac again. In the 1970s and 80s, he got tricyclic, imipramine, and Valium for depression. He was actively suicidal after an overdose. He had another overdose at age 32, and both times these were in relationships to break up of a relationship with the woman, or in age 32 was his wife. He has rejection sensitivity. May have had 2 depressions per year since age 16. very complicated. Married between 32 and 33, between 35 and 36, between 46 and 58. And now he's 60. He's successful physician, psychiatrist, and leadership coach. Leadership coach is an American way of saying, I make more money consulting for industry than I do charging patients. So he is working for companies as well. So finally, he first received lithium at age 43. This is because he wasn't diagnosed bipolar then. He was diagnosed as treatment resistant. Remember the lithium was added on to people. He had multiple medication trial, all with inadequate efficacy, not well tolerated. He took Depakote and hated it, too tired. The physician, remember, doesn't like being tired. Clonopin for sleep. Trileptal is oxcarbazepine, made him depressed. Verapamil, remember when we tried calcium channel blockers sometimes? This made him depressed. Now look at this. Prozac made him woo! But insomnia, headaches, and every time he took an SSRI, he had really bad side effects. Risperdal caused depression. And since he's a physician, he likes stimulants. So he's presenting this history, and he's only taking Ritalin. He's got no history of subsyndromal mania or hypomania, and since age 23, now he's 60, many episodes lasting a week or more of irritability, inflated self-esteem, increased goal-directed work activity. Some of this just looks like a good, normal, successful person who's not sick. But now he has decreased need for sleep, over-talkativeness, racing thoughts, psychomotor agitation, risky behavior. But you know what? It only lasted 3 days. So I went to him and I said, this can't be true. Give me 4. Because I'm a psychiatrist, and I looked it up in the book. And it says 3 doesn't count, 4 counts. Please, please. Wasn't it once 4? No, 1 or 2. Oh, please, 4. I need to make a diagnosis. Oh, you're not manic. Right? It says 4 days. In the book, I looked it up. This is the problem, is that patients don't fit with this category. What is this guy? He's not bipolar, he's not unstable. Actually, you can't make the diagnosis yet. He's NOS. You know NOS? Everybody in my practice is NOS. But it's consistent with subsyndromal dysphoric hypomania. He says 70% of the time he's subsyndromal dysphoric hypomanic, 30% depressed. He hates his life. So let's ask you a very tough question now. With this history, what's his diagnosis? Oh my gosh. DSM-4, recurrent major depression with an anxious dysphoric temperament, A. B, bipolar depression dysphoric. C, bipolar mixed. D, NOS, and we call Dr. Akislo and say, is he at bipolar 3, 4, 5, 6, 7, or 8? What do you think? He probably has a type of mixed, but he doesn't meet criteria. So I think he's got this. Yeah, I agree. He's basically bipolar spectrum, but he doesn't really fit anywhere. Next, how would you treat him? Remember, he's on Ritalin, methylphenidate. This guy, with that diagnosis, is on methylphenidate. Okay, so give him an antidepressant, A. B, give him lithium. He's had it once before. C, give him an anticonvulsant fluid stabilizer. Or D, give him an atypical antipsychotic. Yes, I agree, but that's not what happened. If you would give him an antidepressant, which would you give him? Remember? Or 10, I wouldn't. Whatever would you do on this list? Same list as before. So maybe an SNRI, maybe mirtazapine, many nothing. How about a mood stabilizer? Which one would you choose? Same list as before. Lithium or Lamictal. This man screams Lamictal at me. His case says, I need vitamin L. Lamictal, I think. If you give him an atypical, which one? Quetiapine. Actually, I wouldn't give him quetiapine because every whiff of mildly sedating agent he takes 2 doses of and quits. I think it would work, but I don't think he would take it. So here's what actually happened. I made him stop the Ritalin. I gave him Lamictal. Did he live happily ever after? Actually, he got much stable, very stable, but he was kind of under the line. You know what I'm saying? He wasn't chaotic like he was before, but he was depressed a little bit. He didn't like it, but he was very stable. So what did he do? Normally you should say, well, maybe now we should add an antidepressant, right? No. He decided to stop it. He's a doctor. He's going to do what he wants to. Now what happened? I said, let's give you back your lithium. Because both of those are the 2 drugs you like, lithium and Lamictal. And I agree. But he wouldn't take it if it caused a side effect. Only 0.4. He had a little Crohn's disease, remember? He had a little diarrhea with it. He's not going to have a side effect. He's not going to be bothered. I said, it won't work at that dose. He says, I don't care, I'm not taking it. So what he did is he stopped the lithium and went back on the Ritalin. We are right back where we started from. It's a real case. So now the next question. What would you do now? Give him back his Lamictal. Make him take lithium at a higher dose. Add an atypical. Add an antidepressant. 1 and 2. 1 and 3. 1, 2, and 3, all the above. What would you try to do for this poor man? So 6 which is you would like mostly to give, go back please, you would like to give him lamictal and an atypical. Well, part of the art of psychiatry is getting people to take what they need. Not just giving it to them, but making sure they take it. So here's the next question. What really happened? He agreed to go back to lamictal, but I faked him out. He thought that lamictal made him depressed, remember? So I said, only take half a dose. Of course, I know that 200 works just as well as 400, but he's thinking he's not taking half a dose. I'm going, I'm not losing anything. Then I say, take lithium and take it at a high dose, or I quit. You have to do this. It doesn't work unless you take enough. And he complained, but he finally agreed. And you know what? He's doing great. This is the best he'd ever done. Did he live happily ever after? How long? This is a real doctor asking me this. However, he doesn't like his continued symptoms. He feels desperate, suicidal. He calls me from a California Golden Bears football game at Berkeley, California, from the stadium, saying, I'm in trouble! I feel like killing myself and the people around me. And when my team, which always loses, scored, instead of me getting happy, I cried. Help me! On the phone at the football game. I said, do you have a gun? Thank heavens he says no. So what's happening here? He's on lithium and lamictal. Is he getting decompensation? The other thing is, what is the difference between his temperament and his illness? This man, when is he cured? In other words, maybe the best you can do is to make him not kill himself and not depressed, but really still have a problem. Because the question is, what's the difference between a person's personality and a person's illness? This is not a nice man, actually. How much of this is drug responsive? So let's go and ask the question. What would you do now? He's called you at the ball game. He's on lithium and lamictal. He's going to kill himself and others, and he's taking his medicine. Would you add an antidepressant? Would you add another mood stabilizer? Or would you add an atypical now? And I think most of you are going to say C would be my guess, and I'm right. And actually, you can just skip to the end of the psychotic one. Jason. Is that a psychotic? Is that what's next? What's that? Yeah. Which one would you give him? He's already had Risperdal, remember, that made him depressed. So he won't take that one. You said quetiapine before. Whatever you like. That's good. So, lots of different possibilities. Quetiapine, olanzapine, ziprasidone, aripiprazole. Okay, go back to my, what really happened? I told him to take a Abilify. Why? Maybe that was the last pen I got in the office from the rep that week. I don't know why. I was desperate. I knew he wouldn't take Risperdal. I didn't think he'd tolerate quetiapine. So I said, all right, now let me ask you this. If you give quetiapine to a patient who's acutely psychotic at 10 milligrams or 30 milligrams if they're manic, that's one thing. Would you give a guy like this 30 milligrams of the drug? They would go activated, wouldn't they? Have you used, how many of you used Abilify? It's a newer drug. Do you find it activating in patients who aren't extremely manic or extremely psychotic? Yeah, I think so. And so I started at a very low dose, particularly in a man like this, who is difficult to tolerate medicines. So I said, take this 5 milligram sample and break it in half. And 3 days later, if no problems, take 5. And 3 days later, if no problems, take 7.5. And we'll see how it goes. What do you think happened? He went to New York on a business trip. He took 2.5 and nothing happened. So he took 20. I'm going, what are you doing? He said, Dr. Stahl, I increased my lamictal too. What are you doing? I stopped my lithium. And you know what? I have gait disturbance, tremor, word finding problems. My memory's a problem. I'm so provocative. I'm desperate. Suicidal. I'm going to hang myself. He's not doing what I tell him to do. What would you do now?
Admit.
Well, guess what happened? I said on the phone, he's calling me now from New York. And I said, look, you put the lamictal back down to 200, you put the lithium back up to 1500, and you stop the Abilify, and now we're going to try Geodine. And you better take it exactly like I tell you. Now, have you ever given 20 milligrams of Geodine to a patient like this? If you did that, he would be activated out of his mind. Because low doses of Geodine make people have panic attacks and go berserk. So you have to start at least 40, particularly with food. And you know what? Turn the switch. Suicidal ideation stopped very immediately. His depression wasn't very bad at all. And he lived happily ever after? No. We then, pretty good though. He went like maybe 8, 9, 12 months. Very, very good. But then he decided to add Prozac. Stop this limit. Don't try any Geodine, and oh my gosh. And I called him and said, what are you doing? He won't leave it alone. He's a doctor. He's a psychiatrist. He knows better. He has a hard time being a patient. He has a hard time following instructions. And the story goes on. So the debrief here is that these are real cases, right? Difficult patients are difficult. Patients with bipolar disorder, their disorder gets in their way of being able to take the treatment that even could work. And so temperament and personality are factors in this disorder. And the art of treating patients means to deal with that, because having drugs that work is not good enough if people won't take them. And so a realistic goal may be to not cure him, but to make him better than he was, to keep him from killing himself, to keep him employed, but maybe not to have a stable state. The other thing is that patients don't mind their mixed states, but they hate depression. People around the patients hate the mixed state and don't mind the patient's depression. So this is a problem when you're trying to get a history. The patients don't see things the way that people around them see it. The other thing I should say, have you ever seen this, is that when you over-treat from above, sometimes you stabilize patients too low. But that's not a bad thing. Because a stable depression from lithium or lamictal or Depakote or an atypical can be treated by then adding an antidepressant and you don't flip them. So sometimes getting to euthymia means going through a stage of stable depression. And although the patient doesn't like that, if you warn them in advance that that's progress, that sometimes that's the way to get better. So I told you that I would give you some tips on dosing these drugs. In the manic or psychotic state, Abilify, you can start at 10 to 30. But don't do that if the patient is in the depressed state or is a child. In fact, how many of you think that the dose of an atypical antipsychotic is lower if you're depressed than if you're manic? How many of you think it's the same? I actually think it's lower. I think that patients tolerate antipsychotics in the depressed state not as well. But there's no evidence for what I just said. No evidence. But that's what I do in my practice. In the depressed state, particularly starting patients on aripiprazole, much lower doses than in the trials. The trials say use 10 or 30. If you do that, you're going to get people to activate, vomit, have akathisia, stop the drug, and go crazy. So you have to go slower. And also with aripiprazole, you may need to add a benzo short term to get them to tolerate this. And then they get used to it, and then you can stop the benzo and raise the dose, and then do better. So I would try also, sometimes we even, if someone already has had activation on Abilify, they usually will refuse to take it again. But sometimes we take the liquid. The liquid is 1 milligram per ml. And start them even at 1 ml, and then 2 mLs, and then 3 mLs, and build it up very slowly so they don't get activated. Possibly with a benzo for a short time as well. So these are some tips about using Abilify in very tough cases. How about Geodon? Geodon is very difficult because you should either start it at 60 or 80 twice a day. In fact, both with quetiapine and Geodon, you could probably use it once a day. There's evidence that if you just bang the receptor once in a day, that's enough for people, even though it's not in the blood the whole time. Now, Geodon, only 50% is absorbed without food. You double absorption if you take it with food. If you give 10 to 20 milligrams IM, this is a very good dose. But in the depressed state, you might need a lower dose. But if it's too low, you get activation. This is a funny drug, because with Abilify, if you raise the dose, you get more activation. With Geodon, if you raise the dose, you get less activation. Actually, the funny thing is that this drug is probably better tolerated at 80 milligrams twice a day than it is at 20 milligrams twice a day. And it may well be due to its binding properties. I could give you a lecture on this if you wanted about 5-HT2C receptors. But I think that one of the things that happens is that we give 20 milligrams, it doesn't work, we get scared to go up. Don't start at 20, start at 40, and if there's a side effect, we increase the dose. So you start in the middle and tell the patient they might get springy legs, in which case they're activated. And unlike Abilify, when you're activated on Geodon, you raise the dose. Now, if you're sedated, woozy legs, then you lower the dose. So here's the problem. In some cases, you can have to raise the dose of people, some you have to lower it. But generally, I tell people to start in the middle of the dose range. You can add a benzodiazepine and so forth. So I don't know if we've got enough time. I think there's a third case, but I'm going to just stop here and ask you to do the evaluations for this morning. And we will come back. If you want us to ask some questions, a few of you, I'll stay here for a few minutes, and then we'll go to lunch and come back. Can I have the evaluations, please? On a 1 to 10 scale, please tell me, do you believe that this course this morning met its objective in discussing first-line monotherapy treatments for bipolar disorder on a 10-point scale? Please answer. The next question, this course that is objective of reviewing potential novel treatment approaches for difficult cases of bipolar. Can we meet that objective? Okay. And thirdly, did we meet the objective of demonstrating how to prescribe antidepressants, mood stabilizers, and antipsychotics in combination for two difficult cases this morning from my practice? Next one. I'm convinced that patients with a bipolar spectrum disorder should not be treated with monotherapy antidepressants. Do you think you would agree with this? Next one. I'm convinced that Lamictal is an effective treatment for bipolar depression. It's going to be very interesting for me to see what you said, because I can tell you one thing. As a doctor of practice, Lamictal has changed my practice. I think it's an amazing drug. And it doesn't work quickly. The problem with Lamictal is it takes 6 weeks to get the dose up. And it can take another 4 to 6 weeks to work. So an adequate trial takes up to 3 months. But it very slowly raises the depression in difficult cases, I think. Next one. I am convinced that atypical antipsychotics can be useful for the depressed phase as well as the manic phase. Do you agree with this? I'm convinced that patients with metabolic risks like diabetes, obesity, dyslipidemia should be considered for ziprasidone, aripiprazole, or amisulpride rather than clozapine, olanzapine, quetiapine, or risperidone. Do you think this is true? We're about done. Different countries don't have this drug. Have you had a chance to prescribe Geodon, Zeldox? Yes or no? And then I'm going to ask you if you've had a chance to prescribe Abilify, because those are two new drugs, and they're not in all countries. Have you used Abilify? Yes or no? Anything else? Is that the last one? How about Riluzole? Has anybody in the audience prescribed Riluzole? Yes or no? Most people would say no. Most people never heard of it. Might be a new secret weapon for you. How about oxcarbazepine, trileptal? Anybody use that? sonogram. Anybody use that one? This helps me make new courses if you know these drugs or not. How about Keppra, levetiracetam? Have anybody prescribed that drug? Right, we're done now? Okay, how about the dopamine agonists? Does anybody use pramipexole or ropinol for bipolar depression? How about memantine or romantidine? Do anybody use that? I think this might be the last question. I am convinced that combining multiple neurotransmitter mechanisms is a robust strategy for treating complicated cases of bipolar disorder, especially combining multiple mood stabilizers, lithium, anticonvulsants, and antipsychotics, and then an antidepressant. Do you agree that this is the modern approach to bipolar disorder? Strongly agree, strongly disagree. All right. Please evaluate the effectiveness of Dr. Richardson in the first lecture this morning on bipolar disorder on a 1 to 10 scale. Please evaluate the effectiveness of Dr. Stahl on the first lecture I gave before the break. And then if you would evaluate the effectiveness of Dr. Stahl in the case presentations. We're going to ask you, I would like to attend another case-based prescribing workshop. Do you want me to do this again? Do you like these cases with selections over time? Yes, strongly, yes, or not strongly, agree, whatever. We can make whatever you want. We can make lectures or workshops. You just tell me what you like. What's the next one? For psychopharmacology learning, I would prefer half-day to up to 2-day courses with lectures with a case-based workshop rather than all lectures. In other words, this is the way we're doing it now. You like this mixture of cases plus workshop? It's the last question now, please. All right, ladies and gentlemen, let's have some lunch. We're going to have a siesta after lunch because we're going to learn about sleep. So please come back and sleep in here. If you have a couple of questions, I'll stay here now to sleep lunch.
Most folks didn't know that from that pretest. And also from the lateral hypothalamus comes hypocretin, which is also called orexin. So that's calm wakefulness. The arousal wakefulness comes from a number of different neurotransmitters. from the pons region, such as norepinephrine, and acetylcholine, serotonin, and dopamine. So with normal sleep, goes through several stages. And to begin with, when we get into bed, there is a brief period of time, if we don't have insomnia, initial insomnia, before we fall asleep. And that's called the latency to sleep onset, or sleep latency. And then what you observe here is a cycling through various stages of sleep, and the deeper stages of sleep are stages 3 and 4, where the slow wave sleep, the slow wave EEG traces seen with that, the highly synchronized EEG. And we cycle back up. We see at the top in red hatched areas are the REM sleep, the rapid eye movement sleep. That's thought to be when we are dreaming. And what you notice as well, as most of the REM sleep occurs in the later stages of the night. Just before awakening, we tend to be doing more of our dreaming. What's interesting in terms of the biology of depression is that patients who have depression go into REM sleep sooner than control subjects. So usually the first episode of REM sleep occurs, say, around an hour to 90 minutes after falling asleep. In the depressed patient, that first episode of REM sleep begins much sooner. And also, very interestingly, very quickly after starting an antidepressant medication, that REM latency is stretched out. So now the depressed patient, even before they're recovering from the depression, that REM has improved, so it's later in the night. So that suggests that's an early biological finding, early change towards recovery from depression. So slow wave sleep, which is good sleep, and if you don't get enough REM and you don't get enough slow wave sleep, if you were to wake somebody up when they got to the deeper stage of sleep, or you woke them up when they went into REM sleep, and did that for nights after night after night, they would be essentially sleep deprived. So we need to have those aspects of sleep to get good night's sleep. The neurotransmitters that are important in slow wave sleep are GABA, gamma-aminobutyric acid, and a neuropeptide I don't think we've mentioned much about before, but that's galamin, that's a peptide. And REM sleep is also involves GABA from various nuclei in the brain. Acetylcholine is important as well, particularly from the pontine nuclei and to the basal ganglia. Interesting, the cholinergic neurons in the pontine nuclei are resistant to being killed off in Alzheimer's disease. We don't know why the cholinergic neurons die in the basal forebrain in Alzheimer's disease, but the cholinergic neurons in the brainstem are resistant to whatever is causing the destruction of the cholinergic neurons in the basal forebrain. Now, if you sleep deprived a normal group of subjects and followed them, looked at various parameters such as subjective sleepiness, and doing tests for psychomotor performance, core body temperature, and cognitive performance, there is, now these folks are being kept awake, there is still a rhythm with respect to these different variables. even though they're being kept awake, they feel least sleepy here, where you might be awake anyway. Their subjective feelings of sleepiness come in the morning, early morning, as with the body temperature lowering. The psychomotor performance is worse at that point in time. It improves, even though they're still kept awake, improves